that will present their experience in various sessions. Okay? And we will have a panel discussion at the end of the day, and maybe the group will join in with their own input. So I wish everyone a very good day, and I would like to invite Professor Jörg Engelbrecht, sorry, from Germany. Okay.
Yeah. Okay, thank you for this nice introduction. And sometimes changing names is important, but I'm happy to be here. I'm happy that I was invited by Professor Dieter, and I want to show you where I'm coming from. It's for you. Yeah. So, I think we had already some problems. First was that this computer has a Microsoft operating system and a Microsoft PowerPoint system, which is not compatible with my version because I like open source software. And so I created my presentation with open source, and this was not accepted by that computer. I don't know what that is. Has someone same experiences? Yeah? For me, it's the first time that really this was not working, but okay, so let's see. Oops. Yeah, the best way, I don't know. I'm sitting in the middle of that, so maybe I sit down. And let's come to this interdisciplinarity. Thank you. I think this is a key word for health informatics or medical informatics. And I'm working in this field since 1970, so this is a long time. And we started an institution in Munich, which was the NERIS Institute. We had all different disciplines in this institute, starting, of course, from informatics, starting with operational research, image processing, social sciences, statistics, biometry, and all this. And this was all in one institution. And this shows the big interdisciplinarity we are working in. And at the moment, I'm moving a little bit to the direction of health information management. I will come to that, what it is. And of course, when I was asked to come here, I said, okay, let's see what I can do from my experiences. And this is like a fireworks. I hope it is at the end not like fireworks, which is light and dark afterwards. I hope it will be light the whole time. And so let's see. Health information management is a topic which is dealing with data, knowledge, and information. And of course, as it is health, is dealing with citizens, patients, and it's done for services, and it's part of the medical field more and more at the moment. And so health information management is also maintenance and care of patients' health records. This was a starting point on the paper version, traditional. Now it's more and more electronic, and it's done in hospitals, as you know, physicians' offices, polyclinics, health departments, and whatever you call it. I know that in different countries in Europe the structures are quite different, and I know it very well because I'm teaching in countries which are far away. This is Russia, for instance, in Tomsk, in Siberia. And of course the structures are there quite different, but the need for health information management are always the same, and there is at the moment an increasing demand for this, and I think this is important to follow this demand and try to bring it, as you said, between commercial things, science, and of course real work did. The paradigm of informatics, when I started in 1970, was called clinical informatics. This was rather new in Europe. Then it changed to medical informatics, health informatics. Now it's called biomedical informatics or health telematics. So, but in essence, it's always more or less the same. And of course, we have at the moment, if you look to the program also of yesterday, some hot topics. This is decision support. In our case, it's medical decision support, of course. It's big data is a big problem, cloud computing, quality of data, security and privacy, healthcare organization is a problem at the moment in many countries in Europe. and patient-centered medicine, personalized medicine, qualification of people, information, education of patients, and of course education, training of professionals. And all these topics I will tip a little bit, more details sometimes, not enough details maybe, but the time is limited, and so let's do it in this way. And let's also look what are the key problems at the moment in healthcare, looking from the point of medical or health information systems. The first part is always access to actual relevant patient data. I will come later to a statistic where a study was done in several countries in the world, and it says who is able to see what at the moment. We have had this yesterday also in the first presentation on the question of security and role of people in this system. The second is more important to my feeling, that we have user-friendly data entry, which was if you don't put data in, then you cannot get data out of the system. So this is very easy, and of course you have to do this together with other health professionals, and this will improve at the end efficiency, reduce risk, and return on investments are one of the points in healthcare mostly people don't think about. And I have my experience with medical doctors who say, I should get the data in for whom? For not for me, but for the next doctor? No, I will not do this. So in this case, of course, this is quite different, the view. And the problem we have in countries, I don't know if here in your country, Lithuania, is the same, but in Germany we have it. Terminology is a problem, of course, because medical doctors have their own terminology from school to school, from city to city. And the data items, which are unique to each system, cannot be shared. And we have, of course, but people don't know in normal language, a Bavarian language, we have an Austrian language, which is always called German, but it's quite different, and sometimes the people cannot understand. In healthcare, it's a little bit different, but okay, but it's mostly the same. And so what we have problems is the communication. Of course, also one part is between the internal subsystems, but also external between different institutions, persons, including security aspects, which are quite different in European countries, and privacy. And the first, if you remember from my slide, is big data. Big data is a word which is difficult to understand for some reasons for me. It's because we are working since a long time already with many data. Hospital has, of course, megabytes, terabytes, whatever in data. And so the volume is one description, and this was done in the conference we had this year in June in Prague, and one of the participants said, we have the big V's, volume, velocity, the changes of new technologies, which I've seen. My system is not running here on this, so okay. Then we have variety. This means we have data from many sources in many formats. Then we have the veracity, the reliability of imprecise data. This is important. Who relies on what? Then the value system, which is quite different for citizens, patients, and healthcare. We have the visualization problems. We will come to this in the next session. And we have the variability, different meanings and context of the terms. This, I think, is a major problem. And, of course, how long are data valid, the volatility. These are all the big V's which are allocated to big data. So you see there are lots of problems. Of course, there are solutions, and some solutions are not that young, they are old, but have new names in the meantime. Industry is going to this direction at the moment. You may know ICIST, which is a big company for statistics, medical statistics, and they have also a department which is dealing with big data analytics. And they say, and I think this is important, that big data analytics is a process of examining big data to uncover hidden patterns. And this is important because you sometimes don't know what is behind. Unknown correlations and other useful information that can be used to make better decisions. With big data analytics, data scientists and others can analyze huge volumes of data that conventional analytics and business intelligence, we will come to this topic, or have had this session yesterday on this room, on business intelligence. We will have another talk in the next session, and so they can't touch. So we have of course, problems with data, and it's sometimes not that easy. What we did in one of our projects, which was a research area in Germany called MedVis, Medical Knowledge Bases, we started to use neural networks and put data in as for learning. And the idea was that we had data from patients who died and those who survived from myocardial infarction. And the idea was, can we use this data? These were only 5,000, so maybe it's not big data. But can we use this for a learning network who can then give advice, will this patient survive or not? And at the end, we took half of the patient data for learning, the other half for testing the system at the end. So we had then a result at the end that the system could predict this patient will die or will not die by 85%. This was excellent, so we were happy with that. But then we had a very simple neural network, just one layer. Was because we could analyze this system, and we found, yes, there are several items in which are dealing with this prediction. Mostly was 3 diagnoses. Diagnosis given by a medical doctor, and this diagnosis was not directed or with the disease, with the death, was the disease or not disease the patient had. So we said, okay, this is good, diagnosis, maybe this is the key factor for this prediction. And then we looked into it and we found that diagnosis set, 3 diagnoses given by doctors in hospitals are quite different from those given in private practice. And the system could distinguish between diagnosis given in the hospital and private practice. And people who reached the hospital mostly did not die. So this was at the end the solution, and we stopped this and said, okay, it's rubbish. We have taken this data and we have a good result, excellent, but the way it was running was really stupid because it could distinguish, is it a doctor in hospital or doctor in private practice? And then if it's doctor in hospital, okay, the patient survived. Good. So this, so we have to be very careful with big data because there are data in between, and we have to learn how to use it. And this is on the other side, of course, also a question of data quality. And they have to be defined clearly, as you know, and the best way is, of course, to use standards. We will discuss about this also in the next session on ISO EN 13606. This standard was revised starting in 2001 in Berlin. I was in that meeting, and most of the work was done by OpenEHR and Deepak Kalra, and so this is a way to do it. Of course, there are some other, I will come to this, and we have, of course, a real jungle of standards. Please don't just see this image. And this was given by the Center for Normalization, the European CEN, and this was after they run for 20 years. If someone wants to have the slides, it's no problem. I can give you the slides afterwards. And we had a project called BioHealth. In this, funded by EU. In this project, we tried to find all standards, put it onto a database, to a repository, and then, of course, we found also this picture. And the result at the end was we have about 250 different standards dealing with electronic health records and so on in the medical field just. And the question is who can know about it and what can we do? So we say, okay, let's have this database, have a look into it, and then look for the standard. The problem is some standards are free, you can get it, others you have to pay 20 euros for 2 pages or whatever, people will not do. And of course, what we have learned is people are not knowing about this. The small company Siemens Healthcare has about, at that time, about 400 people worldwide working on standards. And of course, if you have a small company with 10 people, they cannot do this. And so in this case, we wanted to help. The system is still running, but the standard development organization said, we will do it. But they did it. Not so far, but okay. But we are discussing also about the quality of systems. Quality of systems. Depends, of course, on quality of data. And we had in the EUREC Institute, which is an institution which has at the moment 14 European countries as members. Germany is one, and I was in former times a founding member and vice president of that, and which had several European projects. One was the QREC, the quality of medical records systems, and of course we are tried in this case to use description of systems, handbooks, whatever we could get, and try to go out of that source statements. They were extracted from the original EHR system specifications and so on, from certification systems from Europe mostly, but also worldwide from Australia, Canada, US. And we generated out of that the so-called fine-grained statements, grouped them together to best practice requirements, and build a system for using this approach also for test criteria. At the end, we had 1,200 and something different statements. Some of those were just translated into other European languages. I was responsible, together with the Austrian colleagues, for the German version. And so we had a set of, it's difficult to understand, but if you see the use of electronic health records has increased in the last time. And if you, this is a survey which was done by Accenture in November, December 2012. And you see that in doctors' offices in Germany, 93% were using electronic medical records. I don't believe on statistics, because you never know what they mean with an electronic medical record. I know a statistic 10 years before, which was done in Germany on another big company in the field of consultancy. And they had at that time already that 90% of German hospitals were using electronic health records. And I said, how do you measure this? Oh, they said, we are going to the hospital, we're asking each department, and if one department is using electronic health records, we count the total hospital to this statistic. So, of course, this is rubbish. And this may be the same, but it gives an indication that this is a hot topic. And, of course, the EUREC approach of quality measurement, quality source statements is very simple for some people, because we are addressing ourselves to the user, medical doctor, to the developer, to industries as well, to use this for creating their systems, for checking their systems. And as you can see, there's a very, very simple statement. For instance, the system shall create a single logical record for each patient, which is, of course, normal. But you can check the systems against these criteria, and we have set 20 or 50 top criteria, and we're giving a seal for systems which are fulfilling these criteria. And if you see the source statement, this here is the source statement. For instance, the system shall provide the ability to store more than one identifier for each patient record. We have the view when it was created, the source, where it comes from, the source ID, so that you can follow up. This statement comes from this source, from this standard, from this description, and so on. So this is available on the internet, and if you want to give more information about it, of course, it's easy. This is, I think, the main part at the moment. Data of patients, citizens, and systems. On the other side, as you know, we have, of course, the change of the healthcare system and the change of how patients are treated. And I found a very nice white paper by the European Science Foundation. This was in the series of Forward Looks, you see it down here. It was called Personalized Medicine for the European Citizen Towards More Precise Medicine for the Diagnosis, Treatment, and Prevention of Disease. And I took some parts out of it. I recommend to you, if you want to go more into that field, read this paper. It's classical. It's done by many people and across Europe. And it says, first, we will have stratified medicine. Stratified medicine refers to the identification of subgroups of patients with a particular disease, of course, who respond to a particular drug or alternatively are at risk of side effects in response to a certain treatment. This means you should take the data, big data, about all patients and try to classify the patients in it, the results, and then come from this to a conclusion, to a support, decision support, whatever you want to do with this. And this is, of course, an important part, using data. On the other side, personalized medicine, which is taking more patient data, like genes, whatever, and try to use this for a description of the patient and then finding the right treatment for that patient. And of course, it's very clear to me that the way medical doctors are doing it sometimes today, they cannot differently, is not the right way. To say, take this drug 3 times a day. This might not be the right way, because the amount of the drug is not fitting with the disease, with the patient, and of course, so then of course you have to take more data, more information about the patient into account, and then create a better treatment, for instance. And the feature of this is, of course, also, as I said before already in big data, to integrate complex information from multiple data sources. This means taking all the data you can get from the different sources, and then, of course, create an output to support the health of the individual citizen. So there are some recommendations I only took as a moment for my presentation here too. What should be done? Data handling is one recommendation. You should have comprehensive, accessible, interoperable data sets which must be generated to support the development of new disease taxonomy. Yesterday we were discussing about taxonomies as well, and now for its ongoing refinement and application. This is one part. The other part is that you should take data and decision-making processes. They must be revised to reflect a focus on the individual cities, not in general on all, but in the, and then of course look for assessment of safety, efficacy, and so on. And this, you can read this, and who wants to have this presentation afterwards, it's no problem for me to give it to you, because this is some I like to be very open in this direction. So, and the perspective, I think this is also important. You don't have to read the small text. But you see, the European Science Foundation also says, yes, there is a 5 years goal, proof of the principle. Then we have in 10 years the introduction of our new methods. And then, of course, in 20 years total, we have the implementation and refinement of this method. So what we have to do also in our field of health informatics is to look for the next 5 years, then what could be done, has to be done in 10 years, and what is the goal in 20 years. This is sometimes not usual to do so, but I think it's important that you say, okay, we have, of course, this view, and we have new technologies, and we have to develop from the industry side new technologies which fit into this scope at the end. And we have, of course, can also give advice to the industries what should be done in the future. And this may be a different role from the academic side. That we say, okay, our view is this is a new way to treat patients, we need this and this equipment, and please industry develop it. We can develop a prototype, but for routine use, and that we have done in our institution also in the past. The main focus, of course, then will be on communication in healthcare. And you see, this is a classical view on global, regional, local communication. And we had started a project in 1989, which was called DiCard, a diabetes card for patients. This means a chip card, which then was used for transporting data between hospitals, ambulatory care, self-treatment, and pharmacies. This was a European-funded project, and resulted at the end in Germany in the German electronic health card, which was started in 2003, should be ready in 2006, and it is ready totally this year. This means to show really what the development cycles are. And we discussed yesterday about life cycle of software, and you see what life cycle of this is here. And as I said, we had this prototype which was given to the German government, and they decided to make a law that there should be a new health card in 2006, and it's really running now at the moment. And this has two sides. One is the chip inside, of course. The other is it has a European health card on the back side, which is just printed. So with this card, I can go to most EU countries, or all, and get medical treatment for it. And this is given in Germany by the insurance companies. This is a Betriebskrankenkasse, insurance company of a company. And it says, of course, it's designed, this introduction is designed to improve medical care and making processes more efficient. Okay, so they're doing it. We have to remember of that. And as far as I know at the moment, we have the problem in Europe with the refugees. And you may know, of course, as it is in the news, that we have at the moment about 10,000 refugees per day coming to Germany. This means we will have this year about 1 to 1.5 million refugees in Germany from the Balkan states, from mostly Syrian, Iraq, and so on. And all these, there was a discussion, what shall we do with them for medical treatment? And they should fit into our system. So the idea is, and I think it's running at the moment, to give them a free card for health treatment, this health card, and I see how this will work at the end. And there, in this context, Germany founded a company, and Gematik, which was responsible for developing of this card, introducing it, and what's more important, I will come to this later, to the framework behind. And it says this, there are 4 good reasons for the health insurance card. One is improvement of quality, transparency. Then, of course, assurance that the rights and data of patients are protected within an electronically networked healthcare system. I think this is important, that we look, the data are belonging to the patient, and we are, as researchers and as industry, whatever, responsible for the data to take it as it is and care for it. Then, of course, there should be a simplification of information exchange. This is still at the beginning in Germany at the moment with this card. We have a network, first tests are running at the moment, and there are still problems, not from the technical point of view, but from the user point of view. For instance, the idea is that we have here on this card data from the insurance companies, and of course, normally, in former times, we had a card which had to be exchanged if their data are changed. This time we have a card which has some intelligence, and it could be updated online. Of course, it's used in the doctor's office. So the software is designed to go into this card through the network to the doctor's office and update it. No problem, technically. It's running. But the doctors say, hey, we want to have money for it. So this is at the moment the problem. What should be paid to the medical doctors that they allow to use the software to update the card? So as you see, sometimes there are no technical problems, but others. And of course, there should be less bureaucracy with that, and the administrative burden should be lower. And we have function on it, insurance data on it, and it's the only way from 1st of January this year to use this card. Otherwise, you will not get health service in Germany. As I said, the refugees have to have a card like that, otherwise they will have problems. And the main part has changed a little bit, the access to the health telematics infrastructure. I will come to that later. And voluntary is designed for emergency data, electronic letter, medication, patient records, structured the short version, and the electronic patient section where the patient can decide what should be put there. So what we did was this pre-system, which is now 15 years ago and more, have this card carried by the patient from place to place with data on it, diabetic patients. And we had also on the other side our internet, the HCPP network, where the doctor's letter was transported from the doctor's office to the hospital, or from the hospital to the doctor's office. This worked very nicely and was done, of course, by a server in the middle. And you see, this is a total network in Germany we have at the moment. We have about 131 health insurance companies. We have 2,100 hospitals, 21,000 pharmacies, primary care physicians, 270 specialists, and we have 2.3 million other healthcare professionals, and we have 80.2 million citizens. These are all linked into this network. As the telematic infrastructure, we'll see how that works at the moment on a small scale it's running. And we have as a key to it in the middle the health card, which is citizen, and the professional card with the medical doctor. So, and of course, again, the safest connection should be for security, constant availability, nationwide, cross-sector platform, all these nice words. And we have a phase one. This testing, running this at the moment, establishing online updates, secure internet access, and so on and so on. This is really a nice model for a nation. And of course, we have lots of benefits of it. I don't want to go into too much detail at the moment. We have, of course, a case-oriented approach, the Pfizer medication plan, and of course, we can have data for nursing, electronic documentation, and so on. And vaccination is one of the parts of it. So, and the structure behind is very simple. We have on the left-hand side here the different users. These are the doctor's offices, the hospital information systems, and so on, or other patient-oriented services which go into the internet and have connectors to it to be safe and to be sure. Then we have internal the brokers for the different services. So, for instance, this is the Physician Association for medical dentists. We have all this, and they have front ends with their system to this. And we have on the other side, on the back, we have the telematics network with a central infrastructure in the Gematik, in this company, which is doing all the work at the moment. And we have update services here from hospitals, from insurance companies, billing, and so on. And we have a firewall, of course, in between. And we have developed a system which could fit into this, which stands, of course, outside and can be used from the medical doctor on this side through the network. It is tested in another way at the moment, and of course we will hear about it possibly. Will you talk about that? No? Okay, good. Good. This is, the system is called, or the approach is called BioMed Connect. Bi means Bavaria. Of course, Bavaria is part of Germany, but it's paid by the Bavarian government, and it's a medical connection. We have a communication server. This is what later this network should do also. We have this network here on hospitals. We have the network specialists and GPs, and we are tested at the moment. How can we bring data from one point to the other? This sounds very simple, but we have done this in Ingolstadt. You may know Ingolstadt, where the Audi is produced, and they have a network of 512 at the moment medical doctors. They have in the hospital an emergency practice, and this has a certain computer system. And our partner, main partner in Ingolstadt, has an office, private office, doctor's office. He has the same computer in his office. But when a patient of him comes for emergency into the hospital, which is owned by the medical doctors outside, and put his data in, he cannot get this data from the system to his system, even if it's the same system. Then this is, I think, is rubbish, because then the patient comes to his office, the data has to be keyed in again, and you know what is about data quality. The quality is low because errors may happen in this case, so it's much better to get it originally. And this we showed. We had a server in the hospital in Ingolstadt, and this was the communication server here in the middle, and we showed that data can be transported in, of course, in a mapping way. For the mapping, we used the ISO EN standard 13606, open air, or whatever you call it, and of course we had also the standard for visualization of data in this case. And so we had, on the idea was to have our server at the end outside, here, not in hospital, but in this area, accepted by this network, via firewall also, and then of course having here inside the medical doctors who have an approach to all this. It means the whole system in Germany has access to this information way, and okay, let's see if it works. Mostly the problem we had so far is that the project is over and time is gone, and the system, the general system, is still delayed. Yeah, so let's have a look what happens in the different countries. There was an Accenture study which was mainly focused on Australia, but it took other 8 countries and 2,700,000 medical doctors into account. And there were several statistics. I don't trust on statistics, but it gives a hint. If you see here, it says, I have electronic access to clinical data about a patient who has been seen by a different health organization, maybe hospital, laboratory, whatever. And if you see these figures for Germany, then you see that doctors are not interested, 43%, 8% are interested, 12%, no, 8% are using, 15% are not interested, sorry for that, 43 are interested in using, but not using, 8% are using other data rarely, 12% sometimes, and 22% are using this routinely. And from 2011 to 2012, this was risen from 22% to 39%. I have no idea what happened in this time. Maybe the statistics was quite different. And for Spain, you see the difference is even bigger, from 49 to 69%. And I cannot believe on that. But it shows a little bit the relation of what is going on. And if you see this here, that about 20% are using other data routinely. Maybe we have, of course, in Germany, a lab system which is certified, and medical doctors have access to this lab data. Maybe this is the main part. I have no idea, but it's clear there are differences in the countries, and there is some movement at the moment. Maybe this is a simple message of that. The other point is more interest, should the patients have access? So if you go to this city here, you'll find at some points computers, so you can get information about the city. And the idea was in the German system to have these kiosks also for patients to get access to their data. And for this one, it's clear, of course, what are the doctors thinking about. In this case, in each country, they took about 500 in Germany doctors, and they asked what access should patients have to their own data. And you see, 34% said no access. This is data which I have and not. Then 54% said limited access, and only 12% said full access. Even these figures, I don't know if they are true, but okay, they seem reasonable. And you see there are differences in the different countries. The UK people are in the or England in this case, of 34%, say they should have full access. This is 3 times as much as in Germany. So you see, in Europe there are differences, but the tendency for me is very clear. The data belong to the patients, and so they should have access to it. But full access does not mean automatically does not automatically mean that they have a kiosk, a terminal, and have access to it. I think this is quite difficult because you need some knowledge behind to get out of this data the information you want to have. And this is mostly done by medical doctors or medical professionals who can give advice to that, because this is very helpful. Normal people, to my understanding, don't understand what the data mean. Blood glucose, diabetic patients, they know. They are well educated. Other patients, like me and you maybe, don't know each item. Is this normal? What is it? So in this case, full access, yes, but question is how. And what is the result of that? And it's nice to see that these medical doctors rated also that the changing quality of patient care has improved. And you see the differences also in the different countries. In Germany, 56% said yes, it has improved. 40% says, well, it has stayed the same. And 4% says it has gotten worse. So, and then you see Singapore, as a different country, a small state only, and they had 87%, like I explained, said it has improved using IT equipment, using this access to patient data from a previous visit in a different organization. So we should see what can we do in that. Again, what should we do for the quality of health information? One was, as I said before, using this quality criteria for developing systems. And of course, I still have time. And this introduction was done very nicely and starting in Belgium. The Belgian health minister said we should have good quality systems. How can we do this? And then he said, okay, we need criteria. So the Belgium EUREC partner, ProRec Belgium, was asked to create criteria. They created 300 for doctor's office systems. At the end, they condensed it to 100 and said these are the criteria that Belgian doctor's office computers have to fulfill. And okay, fine. How to do it? The solution was the Belgian health minister, the government gives for each medical doctor who is using a system which is fulfilling this criteria 750 euros per year. So the industry is interested to have a certification that their system fulfills this, otherwise they cannot sell the system. And the doctors in Germany, Belgium, maybe in your country as well, are very keen on money. And this is the way to bring them into this. So this is one part. These quality criteria are moving into this direction to bring really good systems or quality systems to the patient. We don't have started this in Germany because when we started this, we had 200 different vendors of patient record systems in primary care. So, and I said, it's impossible. There's never time for it. And so we started more in the direction of the communication standard EHR-COM, EN 13606. Then, of course, we have a strong position, a European position, in HL7. Germany was the first full accepted member. EHR, integrating the health enterprise, also is a part to show how standards are working. And then, of course, we have started education training of health professionals. And just to have this EHR-COM as one part, the archetypes are one part, and they empower medical professionals to define the semantics of their own information system. I think it's important that this is part of the system, that they have clinical concepts which are used by medical doctors who understand what the system really is doing at the end. And of course, this definition is an important step. We have done this. We have a group of, at the moment, 40 institutions which are doing this for Europe. And I don't want to go too much in detail because this will be done in the next presentation by Mr. Kopanisa. So, and it's done by language, of course, the archetype definition language. It's multilingual, which is important for Europe, not so far for other countries like US, which has only 2 languages, Spanish and English. And it's a semantic description of clinical concepts. And it adds knowledge, it has a constraint structure, of course, and it has values. So then, of course, we have the documentation as a classical part in Germany. We started in our scientific society for medical informatics from a society for medical documentation. So we have disease documentation, we have archiving, we have health information systems, we have coding diagnosis, we have 2 major systems in Germany to code it, ICD-10 at the moment, or procedure codes. So this all has to be done. And we have clinical studies, and this is done at the moment at the front end in some areas from the so-called medical documentation clerks, or as they are called today, health information managers. So they have medical controlling, reimbursement, all this is part of their work at the moment. They're doing some research, these clerks, for pharmaceutical industries and universities. They design clinical trials according to the quality criteria and let's run through it because time is going on at the end. So we have then, of course, the interdisciplinarity, which was just discussed at the beginning, between medical informatics, statistics, epidemiology. This is very important. And of course, we're doing some literature research. So we have this classical patient record. We have this documentation in the operation theater, which is important at the moment, directly in the operation theater. We have the nurse, which gives details, the physician, who gives the diagnosis at the end, and of course the code for operations. And then we have this documentation clerk. This is the president, Angelika Händel, of the International Federation of Health Information Managers in the worldwide. And I was impressed by the number of members of the American Health Information Association. They have at the moment 63,000 members. So this is really impressive, and she is at the moment the president. She is a member of my working group on health information management, and what she's done after patient discharge, she checks the completeness, plausibility of the documentation, she checks the grouping, using the 3M group at the moment to get the diagnosis-related group. She sent data to accounting, and of course, this health information managers, in this case Sally-Ann Wisman from Queensland, Australia, has defined top principles for health information management best practice, and let's remember the title of my talk was Health Information Management. And they said, of course, all data items should be clearly defined and the definition made available to all users. And this is important, that the user knows what is the data, what is the meaning behind, what is the structure, and we had a research project in diabetes care and discussed about diabetes data. And the medical doctor, even treating patients, had problems to understand exactly and clear what the single data items are for. So in this case, of course, again, EN 13606 should be used, and the example is the MedConnect project I showed to you. Then we have, I don't know. And the second is that the staff must be skilled in the use of paper forms and collection data collection, of course. Education and training is important. For this IFEMA, the International Federation, has a learning center with modules for electronic health records and so on. Then we have the question, is this data out of date? It should never be completely deleted, which is one of the criteria of CUREC also from health record system. And of course, this is done using commonly accepted design criteria. An example is the EUREC quality criteria for that. Then next is that the health information should be stored in a location which is support timely access and patient care throughout the whole period. Okay. And for this we need trustful certified services. If you see the Medcom network in Denmark, which is running since years already in that way nationwide with all data, this is a good example for that. Cloud computing is coming in this direction, but for some people it may not be clear what cloud computing really is at the moment. Then we have this working group, Health Information Management. You are invited to join it. We have it in LinkedIn. At the moment in LinkedIn we have 438 members, I think, in this working group. And the objectives are very clear to promote the exchange of experience in the development of systems, to promote exchange of standards, and to investigate the needs, opportunities, obstacles for health information management. So this is, and disseminate results in conferences, sessions, and so on. Okay? And the key word for that for me always is capacity building. I did, for instance, 3 seminars in Russia for people who were in the presidential course. This means high-ranking doctors, and gave them some ideas of what's going on at the moment in this field. And this was running under the topic capacity building. In this case was paid by the German economy minister. And there are different levels. I don't want to go into more detail. I still have 10 minutes time, but nevertheless. We have the community way, we have the organizational way, individual, institution level. So we have all to do this. We have done projects in that. One was the self-management of diabetic patients. This was the Empower project, which is now more or less completed in the Helmholtz Center where I was working last years. And this had a sequence of specify the recommendations for patients, and modifying the goals that the patient should reach, then just specifying the actions which would be done to reach these modified goals, then the records, result monitored, the evaluation and feedback to the patient, and of course to the recommendations. And in this case, data were captured of glucose and insulin, blood pressure, weight, meals, physical activities, changing in medication, problems, well-being, sleeping behavior, stress level. All this was done in the internet. You see also here in the internet there is a program which can done by the patient who said, okay, my usual way of physical activity is running this way, and then you get information about the steps and also stuff how you can enhance your physical activities. Then the other way is to bring patients to the system, because they know how to use a TV system, but some of those don't know how to use a computer. In this case, the idea was to bring senior citizens, young people mostly have not that problem these days, to overcome the barriers by joining fun activities. So they could do some fun. They had here, of course, in front of the computer some things to do. They had a special device for it, and they, or others, and can do fun in front of the computers, gaming with a computer, and on this way learning how to use a computer. And the UK people, as another example, they have a health informatics career framework, where you can always see what is the goal, what is your your present state, and how can you get, for instance, from this level to next level. And if you want to become director of an ICT department, then of course you have to fulfill this and that, and this is done at the moment, and this was developed together with the Health Information Management Association in UK and Lorraine Nicholson, and of course she was also one who looked into the IFEMA Learning Center and tried to harmonize it and bring this center into a good shape. And you can go to the web to IFEMA and see what on the website is available at the moment. Okay, then we have, of course, the EFME, and this is the last point for me, the European Federation. You are invited, of course, to become members. And one reason to come here to Lithuania was for me very clear. The Baltic states are not member of EFME. How can we do it to bring them into EFME? The reason is very simple. You have some organizations, some universities working in that field, but not too much. But as far as I know, in Kaunas now, you're starting a course in this direction, so let's see what we can do and participate in these different activities of EFME. The most important is the working groups for me at the moment. Of course, we have yearly conferences, medical informatics, which was in Madrid, and we have it next year in Munich. So of course you are heartily invited next year to come to Munich for the EFME conference. We have a special topic conference, which is next time also important, in Paris. Why not go to Paris? And we have workshops and other things like that. We have lots of members at the moment, 32 at the moment, and of course the Baltic states. My idea was that all three Baltic states could join and become one member. I don't know if this is possible. I know there are differences between the states, but let's see. And at the end, we have good contacts to US, America, and AMIA is the American Medical Informatics Association, and they have an iHealth paradigm. I like this for it. They say, capture information about the individual and apply informatics to create intelligence that drives innovation to improve radically health care. I think this is a nice sentence with lots of I's in, and this is what we will do in the future. I think try to improve health care by using IT in healthcare. And if you have more questions, please contact me, write an email, or I will be here around today, so then we can discuss what to do. And as far as I understand, this is the first step this year to have a session like that. And as far as I can see, it was more or less successful. So I hope we'll continue next year. Thank you. No. Okay. Still 6 minutes time.
I would like to thank you for your excellent speech. There is a certificate and a small gift.
Oh, thank you. Okay, good. So now we are dividing into different groups.
Now it's coffee.
Oh,
Emergency coffee.
emergency. Yeah. Right. And then we are going to see again in this session.
Presenting Lithuanian University of Health Sciences, not a computer science specialist, and my role is to chair this session, which will be held in 4 presentations. First presentation from Maciej Laskowski, automation of color blindness detection in serum profiling framework by Malgorzata Plechavska-Wojcik, but we have replacement here by it will be done by Maciej Laskowski. Third presentation will be energy efficient method for motor imaginary data compression. Will be done by Darius Birvinskas and Vacius Jusas. And fourth presentation will be on comparison of feature extraction methods for ACG, EEG, BCI classification, which will be done by Tomas Ukveris and Vacius Jusas. So I would like to invite first presenter, Maciej Laskowski, to present his presentation.
Thank you very much. Okay, so hello everyone, my name is Maciej Laskowski, I'm from Lublin University of Technology, and I would like to tell you something about colors, about automation of color blindness detection in color-based screening test. So first of all, I will tell you something about color blindness, because there are some myths about being colorblind and not being colorblind, so I would like to straighten them up. I will also discuss the currently used methods for detecting color blindness, and then I will show you my method for detecting color blindness based on applications, computer applications actually based on computer games, and then I will prove more or less that my method is working by showing you the experiment results, and then if the chairman will allow me to, I will sum everything up if I keep in time. Okay, but first of all, I'm from Lublin, and we're now in Lithuania, and I would like to say just 30 seconds about one particular place in Lublin. In the very center of Lublin, there is a square which is called, I don't know if you can see, but it's called Plac Litewski. It means the Lithuanian square. There is a very particular monument with a very particular relief. Here's the monument, the obelisk. Here's the relief. Look at the coats of arms. Here's the Polish white eagle. Here's the pogoń of Lithuania. And on the June 1st, 1569, in Lublin, the Union of Lublin, surprised by the name actually, was signed, making Kingdom of Poland and Grand Duchy of Lithuania one country. And as you can see, this is the size of our country, superimposed on current borders. So morals from the history: when we cooperate, we become great. So if you would like to cooperate with me after listening to my presentation, feel invited. Okay, but let's get back to the main topic. There are few different methods of categorizing color blindness, because there is no one general type of color blindness. There are several types of color blindness which can be classified in many different ways. For the sake of this presentation, I will use the following classification. There will be 3 categories: proton, deuton, and triton. Proton means red-green color vision disorder, deuton means red-green color vision disorder, and triton means blue-yellow color vision disorder. As you probably know, we have 3 types of photoreceptors in our retina: the, let's say, red, blue, and green. And each category means that the main color here, red, green, and blue, the receptors for this color are either totally missing, which means that you have protanopia, deuteranopia, or tritanopia, or the color, the number of the photoreceptors of that specific type is reduced. So you have proto-anomaly, deuteranomaly, or trit anomaly. Color blindness can be both inherited from our genes, so it can be congenital, or it can be acquired by some illness, by some trauma, by being intoxicated, and so on and so forth. So in case of illnesses, it may serve as a diagnostic clue that something is wrong. If you had normal, let's say, perfect color vision, and now your color vision is slightly more or less impaired, it may suggest that you are ill. And it may suggest that you have optic neuritis, you have diabetes, you are, let's say, old because our macula degenerates over time. It also can mean that you have sclerosis, the very early stage of sclerosis multiplex, Parkinson, and so on and so forth. In case of intoxication, it means that you are under influence of LSD, Tuyon, or certain mushrooms, if you want to know why your color vision is impaired right now, but it wasn't impaired earlier. Anyway, so in case of being a color blindness, being a diagnostic clue that something is wrong, something you are probably have the first symptoms of some more or less serious disease, you should be able to monitor your color vision. But the problem is that the majority of color vision tests are done only during some screening tests at schools, while you're applying for driving license, and so on and so forth. So, because the acquired color vision disorders may appear at any time, you should be able to monitor them, and if they appear, you should be able to react. So, you need a method which will allow yourself to test yourself, or a method for a doctor to test his patient quickly, cheaply, easily to monitor, being easy to implement and easy to use, and so on and so forth. So, we need to check if color vision is good or color vision is bad, so we should use some method for detecting color blindness. So most of you probably would think about Ishihara plates, but I would like to tell you about a few different types of color vision detection methods which are used today. So first of all, pseudo-isochromatic plates, meaning the Ishihara plates where you have to read some kind of number or some kind of letter. Actually, in case of Ishihara, these are numbers from a certain pattern. We have also spectral methods, lamp methods, and arrangement methods. Each category has its own pros and cons, but actually they may differ even within the same category, which means that even if you have methods which are based on the very same fundament, the very same basement, for example, different types of pseudo-isochromatic plates, it does not mean that they have the same sensitiveness to detect color blindness. So, as you can see, pseudo-isochromatic plates means that you have some number and you have to read or some letters or some drawing, and you have to read it from the plate, which is scattered with different points, which may appear as having the same color for a color blind person. Spectral methods means that you have a sample color light here, and you have to create the same light by mixing different types of light. For example, you can somehow acquire yellow light by mixing in certain ratio the green and red light, and by checking the ratio the patient is using to create the sample light, we can detect if he is colorblind or not. The arrangement methods, when you have to arrange a certain dots or a certain let's say things because they differ in a certain order. For example, from the lightest to the darkest, or from blue to purple, sorting them as you think they should go. And lamp methods actually does not check your color vision recognition. It just checks the ability to perceive a traffic light or navigation light colors. So you have a lamp for example, with different colors in each corner, and you have to just say what is the meaning of this particular signal in navigation. If you know the meaning of this particular signal in navigation, for example, here are two brown lights, here is the green and the red lights. So if you can differ those two signals, you are allowed to, for example, be a sailor. But it does not mean that you are considered colorblind or not. It just checks if you are able to understand the signals. As you probably know, each method each diagnostic method has a sensitivity parameter, which means how many true cases, the true positive cases, are detected, and specificity, which means how many true negative cases are detected. Those methods I presented a second ago do differ on those parameters based on who is conducting the research. As you can see, they may differ significantly from 50% to 87% of true cases detected. 50% of sensitivity means that I have the same sensitivity as flipping the coin, right? And for example, specificity at 33% means that considering if somebody is colorblind or not by flipping the coin will be more accurate than this method, right? Of course, there are some methods, for example, anomaloscope, mixing the colors in certain ratio, which are considered gold standard, which has the perfect score of colorblind and non-colorblind persons detected, but they have some different, let's say, characteristics or limitations. For example, Ishihara plates can be used at least from the 6 years of age. They cannot detect triton disorders, they cannot specify dichromatism, and anomalous dichromatism means that you are totally colorblind on that specific color, or just you have the limited color vision. And they have a parameter of top accuracy up to 2 years. So after 2 years, the colors on the print are fading, so you should replace the booklet with the plates. As you can see, there are some time-consuming analyses, unsuitable for screening, and so on and so forth. But as I mentioned, the anomaloscope is the gold standard, right? So, okay, screw everything else, use the anomaloscope. There is one actual problem. The price is from 6,000 euros, and actually it requires trained personnel because the analysis of the results is pretty laborious. So first of all, it's unsuitable for screening tests, and secondly, I think that no one would buy an if my color vision is okay or not. Of course, those methods have computer implementations. They have been implemented many times over. The implementations differ on quality. The implementation, basically, even if it's correctly implemented, has the same sensitivity, in best case, and specificity as the original version. And the first problem is that it does not engage the person who is tested in the testing process. So the people think that they must test the color vision, they don't want to test the color vision. Okay, so I decided to break the wall and try to use computer games as a diagnostic platform. So there are testing elements, I named them quadlibets, I will explain that a little later, which are implemented into the game in order to raise the immersion. Raise the immersion means that you want to engage in the process, you want to take a part in the process, and the decisions and actions of the player are analyzed in order to detect the potential color vision disorder. There are 4 phases and 125 quadlibets. You have the algorithm here. Actually, the algorithm is not interesting as what's that, right? Quadlibets, what suits you, are the pairs of colors which are hard to distinguish or impossible to distinguish to called confusion lines or confusion axis. These lines show that the colors here, 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 and here, here, and here, and so on, are impossible or are hard to distinguish by a person type of color vision disorder, right? So for the protons, for the deutons, for the tritons, the confusion lines into confusion zones in order to classify if a person is totally colorblind in case or just have a impaired color vision. I have also created quadlibets in order to use them as a control factor. These quadlibets use colors which are possible to tell apart, not actually to name, to be named properly. The part, this is lighter, this is darker, right? So I can tell which color is which. I can tell them apart. Here's the example of the quadlibet. Here's the color. Here's the second color. And for example, people who is protonomalus, who has impaired color vision but is not totally colorblind in the proton type, should tell those colors apart, but person with protonopia should not be able to tell those colors apart. Of course, the presenter a little, let's say, lies about the quality of the colors here, but on the computer screen they present pretty well. But I think that you can see the difference, that you can tell apart that this color is different than this, but you will have some troubles with detecting those two colors. Okay, so let's get back to the games. The first game was pretty simple. Actually, there was some pattern color here, and the user had to decide which one of those two squares is the same color as the color on the top. It was just made to test if I created a good pattern a good set of quadlibets for testing each kind of color vision disorder. So I made research on two groups, which each of those groups was 12 persons, and 100% of real color blindness cases were detected. One group was consisting of persons with already detected color blindness, and the second group was consisting of people with normal color vision tested by the doctor using Ishihara plates, and 0 false negatives, 25 false positives in control group before I implemented the error threshold. The error threshold means that you have to, you may make some mistakes. Actually, I decided that on each color pattern, on each type of quadlibet, a user can make 2 mistakes. And after implementing the error thresholds, 0 false positives, so the method seemed like working. So I conducted the second experiment with over 300 persons involved, without any previous knowledge of the color vision quality. And after testing them with my method, I also tested them with other detection method. Actually, it was Ishihara plates and the 15 pane. As you can see, 100% of real color blindness cases were detected, and I reduced the number of patients which required to be examined by 75% or by 90% with or without error threshold. What does it mean? Actually, I thought that using my method for screening test would allow me to test if somebody may have color blindness or not. So, if my method suggests that somebody may be colorblind, the automated diagnosis should be confirmed by the doctor, right? But if my system says that somebody is not colorblind, the diagnosis should not be confirmed by the doctor. So I will reduce the number of patients requires confirmation and requiring further examination or whatever. Because as I mentioned before, it's not it's mainly for acquired color vision disorders. So if somebody shows the possibility that he is colorblind, it may be a diagnostic clue that some serious health problems may occur, so he should be checked by a doctor. Okay, but selecting two squares was boring, so I decided that I should go further. Here's a skid game. A skid game means that you have two plates flowing in the air and you have to shoot them. Right, so I decided to create a simple game based on the skid game. One plate is flying from the one side of the screen, the second plate is flying from the second side of the screen, and the user had to shoot the plates. I also create two groups, 1 person with various types of color vision disorders, 12 persons with normal color vision. Also, each case of color blindness was detected, but there was an see the doctor because the plates were moving, right? So people were making some mistakes. They were not aiming properly, and so on and so forth. But the most important factor: no false negatives. So no person who is colorblind was said not to be colorblind. And the third game, actually, you cannot see very well on the screen, but here's the 3D game Maze, and there are some clues. Here are two paths. One is black, one is yellow. There is a yellow orb orbiting in the center of the chamber, means that you have to follow the yellow path. And when you go to the second chamber, the color changes. So the aim of this experiment was if changing the environment of the game from 2D to 3D will affect the diagnosis in any way. The same amount of people as in the second experiment, 12 persons with color vision disorders, 12 persons without color vision disorders. Also, each case of real color blindness was detected. Only 16% of false positives were, the increase was noted, and no false negatives. And because I'm running out of time, the conclusions. It is possible to detect color vision disorders by analyzing the decisions and actions taken by the player during the game. Such features as reflex or agility, they do have a negative impact on the diagnostic case because people were missing the plates flying in the game where we're shooting wrong. And if you want to switch your game from 2D to 3D, it almost has no effect on obtained diagnosis. Paradoxally, it means that it's easier to create a two-dimensional game than three-dimensional game. So probably if this method will be used in medical rooms, probably it will be based on two-dimensional games. Okay, questions, comments?
Okay, thank you.
Sorry.
If anyone wants to ask questions.
What about monitor or computer screen color management?
Yeah, that's the main problem with displaying any colors on the screen. Actually, I'm using the sRGB color space. It's the color space with the lowest, let's say, number of colors possible, and within this color space, I've created my Quadlibets, the parts of colors. So as far as I know, because I've checked on different types of monitors, using sRGB as a space as a color space for the games minimizes the influence of the type of monitor or display device on the diagnosis. Under one condition. Good lighting, more or less natural, and the proper distance between your eyes and the computer monitor, about half a meter. And there are almost no differences.
But what about introducing some
color correction schemes before the game, let's say, for monitor adjustment?
If I in case of medical room, it's not a problem because you are able to correct everything. You can set up the computer, the monitor, the displaying device, whatever, properly and as you want. In case of those games being played at home, it's pretty hard because I can of course write a set of instructions before playing the game. Follow these rules. Check if this square is white. Check if this square is black. If not, adjust your gamma or your contrast or whatever. But the problem is that it may be difficult to some users. Again, may, underline the may, right? But I'm thinking about including some instructions, as I mentioned, for the players. Adjust your monitor based on those 2 or 3 points. Check if this is red. Check if this is white, and so this is black, this is white, and so on and so forth. Because the problem is that if somebody is colorblind, more or less, he may set the monitor in order to meet his needs, right? So it will actually, the colors will not be displayed properly in case of normal colors, right?
Just one question. When you check if you have hearing problems in some cases,
Yeah.
you used to adjust the volume to tell when you hear some noise. Did you think about using something similar to colors, adjusting the amount of red, for example, components?
Actually, it's the same. It's more or less the same idea as the anomaloscope, right? Because you have a mixture and you have to adjust something. The problem with the hearing. With the hearing test, for example, I'm deaf, by the way. I have absolutely no hearing in my left ear. Is that there is also some muscle reaction because when they play the sound, it takes more or less a few milliseconds or something to press the button, right? But in case of vision, you don't need to be exact. But as far as I know, that's what you're talking about. It's a variation on the anomaloscope, right? There were some computer implementation of the anomaloscope, and they may the results of the research suggest that they may be used in order to detect color blindness, but only somehow on the CRT monitors. I have no idea why. I have not researched that field. But people who are wiser than me say that, okay, on the CRT monitors, it is proven that it's okay. On the LCD LED monitors, not yet checked. So it's a field which is worth researching, but maybe next year I will be able to to provide you with more details.
Okay, thank you very much for your presentation. We have no time for more questions. I think this is very interesting topic we can discuss in the coffee break. So I would like to ask you to present a second presentation.
Yes. Okay. So hello again. Okay, I'm not Dr. Plachowska-Wójcik. I'm here as a replacement, and just to straight some things up, I will not be able to answer any questions about the presentation. I've read the paper. I know about her work enough to say what's on the slides, but I have no further knowledge, and I don't want to create some kind of mess. So if you have any questions, please. Write an email or tell me. I will ask Dr. Plachowska about your questions, and I will mail you the answers. Okay, so GMM-based molecular serum profiling framework. Okay, let's move on. If you need to be checked if you may have cancer or not, one of the methods is to check your blood for certain proteins. And You have, of course, it's not. This does not only appeal to oncology, but also to different fields of medicine. But here are the cases from oncology. If your blind is checked for certain proteins, it may induct that you may have cancer. But the problem, first of all, your blood changes. In the morning, you have different chemicals in the blood than in the evening. You are tired, your blood analysis results will be lower than when you are well rested, and so on and so forth. Also, you have a large amount of data which needs to be sorted out in pursuit of some interesting indicators that something may be wrong, more or less. If you have, for example, the spectrometer using the MALDI-TOF type, you have the following steps to fulfill in order to provide the complete analysis. You have to correct the noise. You have to set the baseline correction. You have to normalize the results left after correcting the noise and the baseline, and then you have to align the spectrum. And by combining those methods and some additional methods, Dr. Puchowska created something which is called Framework for Proteomic Mass Spectra Analysis. Because the problem is that you don't, for example, if you are correcting noise from the samples, it does not mean that you cut some of the values which do not make the threshold. Well, basically it is, but the problem is if the same values appear on one sample, on second sample, on the first sample, and on the 110th sample, which were collected, let's say, for about a year or 2 years, it may induct that it's not a noise. It may induct that something is here. You should not cut it out, right? So, in order to analyze the data, you have to prepare it right. So you have to normalize the data. You have to interpolate the data which is out of the scope. You have to check the consistency of the dataset mean spectrum, and then you have to pre-process the data to correct the baseline. So you have to identify and subtract the base level of indicity present in the spectrum, which may differ in each patient. You have to detect the outliers and remove them based on signal to noise ratio and analyzing the AUC value, area under curve. And you have to remove the noise, so you have to smooth the signal, but remembering what I just said before, that if some noise appears in the very same place for a set of samples collected over a wide time frame, this may not be noise. It may be something interesting. And after that, you have to identify the peaks. So you have to identify which substance, which chemical is present in the sample, and the data about the proteins is modeled with GMM, with Gaussian mixture models. And those parameters for those models are estimated with expectation maximization algorithm. And then, when you have all the unnecessary stuff reduced and you have the peaks identified, you can check if the distribution of the proteins is normal, if the amount of certain proteins are within an acceptable range, and so on and so forth. The data for the normal, let's say, amount of proteins in the blood are from the biology databases, which are gathering data during some research, during some medical procedures. So you are able to tell what's the minimum acceptance level and maximum acceptance level of something we may call normal state of or normal amount of the certain protein in your blood. Okay, so let's look at some figures. Here's the original sampling. After the baseline correction, as you can see, we have removed some of the data here and some of the data in the very top. Then we remove the noise, so we can flatten the whole. Spectrogram, and what else? We remove the outliers, so we just have this part of the spectrum, which may be interesting. And after identifying the peaks, we are able to check the values for each peak and check if it's meeting the minimum or maximum size of the protein level. And here are the results. Of course, probably to majority of you as well, to me, this numbers does not mean anything particular, but A means that here's the difference between normal patients and patients with certain type of gastric cancer. B means the difference between normal healthy patients and patients with early stages of that cancer. And C means difference between patients with advanced cancer and early stages of cancers on certain protein levels. And as you can see, there is a huge difference between normal patients and patients with advanced cancer. So, conclusions. The framework provides features which enable to process the analysis automatically. Parameters which are set automatically relate to all the steps of data preprocessing, and the framework and the procedure automatically adapts to the data set, choosing the correct number of peaks. So, basing on the spectrogram, you are able to adjust the number of identified proteins. Okay. Thank you very much. In case of any questions, please, I will go to class. Okay?
Thank you very much for your presentations. I will give you both. Okay, now it's time for Darius Bilinskas to present his work.
Hello, I am Darius Bervinskas, and I am going to present an energy efficient method for motor imagery data compression. Motor imaginary data is a fancy way of saying it's an brain electrical activity. Now, in recent years, some interesting portable EEG devices are emerging, and ambulatory EEG monitoring is becoming possible. The problem is increasing volume of data, because these portable devices have to transmit data through usually wireless channels, or you have to store the same data in on-board storage, and in these devices data compression is usually required. Application for this, as I mentioned, is ambient assisting living. EEG portable monitoring devices can be placed on patients at home and monitor in their natural environment. Another application could be brain-computer interface, when, let's say, data is acquired from a human brain, then some computation happened and the computer doing some stuff, like moving cursor or spelling devices, and stuff like that. So, we propose method which is aimed for portable, low-cost EEG recording devices, where data compression is required and small data loss is acceptable. It's not, let's say, in medical purposes or in medical lab when you have to measure exact data and you cannot lose any peaks or some high frequency noises. This is same for measuring when in compression when some data loss is acceptable in loose compression. And what we propose to use fast discrete cosine transform algorithms and remove some e.g. DCT coefficients and store or transmit data, and we need to reconstruct data, just fill this removed coefficients with zeros. So, discrete cosine transform is a method of transforming time domain into frequency domain. It means it can convert a series of time into frequency components, and low frequency components are concentrated in first coefficients of DCT, while higher frequencies in last ones. As we know, EEGs usually have information in lower frequencies, so this transformation is very suitable. And other properties of transformation is good energy compaction. It means it can concentrate energy of signal into few first coefficients. And another good thing about it is many fast computational algorithms were implemented over the years, and these algorithms are very suitable to implement in hardware description languages or embedded systems. And in my research, I comparing a computational speed and computational accuracy with this formula implementation, which is low, against these three fast DCT algorithms. And I'm comparing how different algorithms, these algorithms are implemented in fixed point, how this affect data loss. So we have a method, and now we need some data. We used a multi-epoch recording device, which is pretty low cost EEG recording device. We used OpenVibe framework to implement a motor imaginary cues with online feedback. It means that on every trial, second, some, I don't know, you can see it, green square appears on the screen, and after 1 second, when user sees the square, a red arrow appears, and the user must imagine that it's using right or left hand according to this arrow. So if the arrow shows to left, the user should imagine it is using the left hand. And 200 trials were recorded, and we made experiment. Experiment consists of basic 7 steps. Each trial partitioned into a set of 8 samples. It's a limitation of fast algorithms. Now, DCT transform applied on every sample, and now some number of last coefficients are removed and shorter vector is constructed. So this is compression steps. In this time, some theoretical transmission happens. Now 4, 5, and 6 steps are 4 and 5 actually are reconstruction, and 5 and 6 steps are quality measurements. So, how to evaluate results of experiment? There's 3 important things. First of all, of course, it is compression ratio, how much data was saved, data volume, and another is percent of root mean square difference, which measures how much data was lost after reconstruction. This was chosen in front on peak signal to noise ratio because it is measuring not peak data loss, not peak error, but average error across whole data set. And results. So first of all, time results. When using DCT formula to compress in the compressed whole data set took about 3 seconds. Using fast DCT algorithms, it took about 1 second. And this nice picture shows how compression ratio is increasing, and in the same time, peak signal reconstruction error is increasing. So if you have a compressed signal by 2, it's about 5% loss. And another thing, we can see that all 4 algorithms is basically showing the same results. So these fast algorithms is suitable and can be used in, let's say, embedded devices. Results are in line with other authors' works, but they are using much more difficult algorithms. And this, as I mentioned, these fast DCT models have significant advantages in terms of compression reconstruction time. So, conclusions are simple. Lossy compression techniques using discrete cosine transform can be acceptable in some applications, usually at home in portable devices where data loss, small data loss is acceptable. Pursue proposed EEG compression method ensures reconstruction quality is in line with other author results, and fixed point algorithms can be used for EEG data compression. Thank you for your time, and if you have any questions, please ask.
Thank you for presentation. If you want to ask any questions.
You said that there is 99.5% data saved. And what about 0.5%? Is it not important, so we can lose it?
It depends, as I mentioned, for applications. Other authors suggest that even bigger loss is acceptable for automated, let's say, epilepsy detection. So, yes, I think this 0.5 is not important, and it's usually some noises, not real signal.
Is it possible to create any program to correct losses or to correct loss?
I don't think so, because we don't know where the losses are. We need some prior knowledge to correct them.
But the ECG has own peaks, so it probably could be some of data can be restored.
It also has peaks after reconstruction, so it's very hard to notice the difference. Even if you have constructed and reconstructed data blocks on top of each other, they just covered. And some very small peaks lost.
Okay, thank you for the presentation. Please take a certificate.
So, hello all, I am Tomas Uktveris from Kaunas University of Technology. I am from software engineering department. I'm a second year PhD student, and I will be talking about today about comparison of feature extraction methods for EEG BCI classification. So let's do a quick recap. What is BCI? BCI is a system that allows
to control computer applications by using a human mind. To reach this goal, we need to analyze the recorded electric signal from the recorded from the human scalp, and there are many obstacles to reach this goal. First, the signal is very contaminated with noise. We have many artifacts. We also need very accurate feature extraction and classification methods in order to understand the signal correctly. And since this field is transitioning from binary to multi-class classification, many other problems arise. So the research aim is to compare different feature extraction methods and compare also different classifiers with them, and to determine which of those classifiers and feature extraction methods are the most promising today, and also lay the foundation for further analysis in the future. So we're examining a 4-class motor imagery problem, and in the process of this research, a new method was introduced, which is called channel difference. So let's recap that a BCI pipeline consists of a subject that is connected to some hardware, which records the electric signals from the human scalp surface. The subject is instructed to imagine some motoric action, and we in the signal processing and classification in the computer, we try to guess what is the correct answer, what the human subject imagined. Okay, so the signal processing part composes of typically of 3 components. That is the pre-processing step, in which we use the bandpass filter to filter out only the brain waves from the whole spectra. There is also the feature extraction step, where we do additional optional pre-processing. We calculate the features, we generate the vectors, and finally we classify those vectors. So let's look at those steps. In the pre-processing step, there can be many filters applied, and one of those filters usually used are bandpass filters. Also frequently used is the common spatial patterns, which we also applied in our research, that tries to separate the signals to find such a transformation that maximizes the difference in variance for both of those signals. So we analyzed 5 different feature extraction methods, and I will quickly cover them. The signal power is the simplest one, which computes the average power of the signal. Time domain parameters involves the first k derivatives of the signal. Tiger-Kaiser energy operator also works with first and second order derivatives. And also there's frequently used the band power features, which divide the whole EEG signal into several bands, and the energy of each band is computed separately. And there's the channel difference method, which we propose. That is, this method is taking into account different channels, different neighboring channels on the human scalp. So what we do when we compute this channel difference features, we first select the channels from available channel set. Those which have or more from 4 to 9 different from 4 to 9 neighbors. In this case, from international 1020 electrode system, we used 4 channels for our computation. It's recommended to use channels which are symmetrical in both parts of the brain to cover the left and right hemisphere to capture all the motoric actions in both sides. Then we, for each of those selected, that is the boldly selected channels, we apply the Laplace filter shown with the kernel. As shown with the kernel, we do a convolution, and from that result we compute the band power features on the result, separating the result in 4 different bands, equally distributed bands. So the classification stage, we analyzed 4 classifiers. The implementation of the program was implemented in MATLAB, used BioSig toolbox for biosignal analysis, and also libsvm was used. We selected a data set from BCI for competition, which is freely available on the internet, which contains data of 22 channels for 9 subjects, and for each subject there is 288 trials of motor imagery data. So how we measured accuracy. First, the classification was validated using a tenfold validation, cross-validation scheme, which is a standard procedure. Then we use the Cohen's kappa coefficient, which is also recommended for EEG-based applications. So the results for the channel difference and common spatial patterns can be seen in this slide. On the left you can see the different features, and on the bottom there's the kappa value. If we look at the results for when no common spatial filtering is applied, that is the red bars, we can see that the channel difference is more superior than all the other simple non-filtered versions of the features. Now, if we apply the CSP or common spatial patterns method, we can see that it gives some better results than our channel difference method. But if we average the results, it would be very close to the channel difference method. There's no error in this, since if you notice that there's no bar on the bottom, no blue bar, because we cannot combine channel difference method and CSP filtering. Okay, so CSP filtering results for different classifiers that we checked. As you can see on the left, CSP does a positive improvement over the results. So filtering the signal, so to filter the signal, it's recommended to filter the signal, and you can see that the TDP and mean power features are those that contain the best results in the area. Also, on the left-hand side, we see no CSP filtering, and there's also a bar. The first bar with the blue bar, also with the results that shows the channel difference method. So, if we look at the different view, that is, if we look at the results per subject, these results are for the CSP filtered method, we can see that some subjects like T5 and 6 and 2 and so on are very immune to the methods that we are using today. That is, that it provides an intuition that we could use that we need an adaptive methods that can adapt to each subject individually. So, to conclude, we have seen that the mean power and TDP features perform the best in our tests. Also, the LDA classifier was the most effective one and showed the best results also in our tests. And with this LDA as the top classifier, we can also say that the data that we classify, the complex brain activity, can be truly linearly separated. So, also about the filtering. Filtering, as I said, filtering step is highly recommended. It greatly increases the performance of classifiers. Also, the channel difference method that we presented performs almost in the same as CSP method, and but outperforms the simple, not filtered feature extraction methods. And also, from the previous slide, we could see that that in the future we need adaptive methods that can really adapt to every single subject, not to walls, not to generalize all the data, but to adapt to the subject specific, as everyone's mind is very different from the others. So, thank you for your attention, and if you have questions.
Thank you for presentation. If you have any question for presenter? No?
In your method that you presented, you said that only channels are selected that have 4 nearest neighbors.
4, 5, up to 9, yes.
But so there are more channels in this experiment that have 4 nearest neighbors?
Yes, we also mentioned that we should take symmetrical channels, which were not included. What the channel difference method allows is to, if we have 22 channels, it compacts the channel data. So if we do filtering, we select only 4 channels, we can combine the information from those many channels into much less channels. Many EEG systems use 100 or more channels. It's very difficult to pass a lot of data to classifier and to train a classifier with not having a large data set. So this method also allows to compress.
I have another question, but C3 and C4 are normally standard areas to use in motor image. So if there were more channels, would your algorithm select more points?
Yes. More points that are symmetrical on the head and cover the both left and right hemispheres.
Okay, thank you for your presentation. Please take your certificate. Okay, thank you.
Thank you.
I will say for chairmanship, Professor Varga. Thank you very much.
So our session is closed. Now it's time for
Now it's time for inaugural industrial session presenters, and we will have a short technical break for 5 minutes for the presentation. presentation of industrial leaf, and I would like to invite Thomas Blažauskas to the presentation on biometric smart t-shirt technology.
So, hello dear colleagues, nice to see you here, and most of you know me. Usually I work at KTU, but sometimes when there is some interesting project, I work some industrial company, so this will be the project I'm starting to work on, and I will tell you about wearables. I will talk about the smartwear, the t-shirt, smart t-shirt, but also I would like to talk about other healthcare technologies we are working in our university and companies. So, to start, very short introduction. This topic has been known for years for IT people, I mean for IT professionals, as well as for healthcare professionals, and there is even the field known as mobile health, but for the public, this is relatively new, and it became known as we got the applications which got popular and are really changing people's lives. So what are the devices which are included in our mobile phones, which can be used to gather data which we use in our healthcare applications? So very simple creative applications use just mobile phone's flashlight and camera to detect pulse. The holy grail of all smart devices, smartware devices, is the accelerometer. And for those who don't know what is accelerometer, as we IT people are joking, it is the device which calculates the speed on which your phone approaches the wall. So we have other devices. We have near-field communication devices which we can use for authentication. We have GPS and we have the old micro, which can be used to detect human some statistics, and we can, for example, determine some sicknesses which can occur in some cases. So the mobile health, the abbreviation is mHealth. Usually it tells us that we have a mobile device which should not even be the smart device. We have digital assistant. Usually we have both in the one device, and we have lots of variables which we use to gather the data. So this nice picture is from the Europe Commission web page, and using the data we can do some health monitoring, and two actors which usually exist are the professionals, for example doctors, trainers, other people, and the persons who wants to monitor their health. Europe Union and Vodafone Foundation, they such the categories, and with our project we basically aiming at diagnostic and treatment support, as well as on remote data tracking and monitoring. So talking about the wearables, we have lots of them, and if we start from the human head, we had recently the session about the stuff. So this is a brain computing device, which we cannot use, I think, for controlling, for sophisticated controlling, but it's quite good at getting data about human brain activity. Okay, we also have smart glasses as wearables. So you see here Google glasses, which never came out. These are not so useful for data acquisition, but it's good for data visualization. And the new toy, which will arrive into the world, this is Microsoft HoloLens. Like the name says, we should see some hologramic pictures, but this for real is just artificial reality. But what is good that Microsoft gives us virtual and augmented reality framework. What we have more, we have the necklaces, the smart necklaces, which use accelerometer basically, and these necklaces can provide also some information. For example, using these light emitters can show our progress. In order to get the data on our heart rate, we use so-called chest bands. And as I said, we can get data on heart rate and sometimes on our breathing rate. When we go further, we can have some armband devices. This armband device, it has also uses accelerometer, it has communication means, and in Lithuania it's not so popular. It's about 50 to 100 euro, but in foreign countries it's very popular. For example, people are using it in their job institutions. The employers, they give out such armbands, and we use some kind of a gamification to provide some bonuses for their employees who do some active style of living. Okay, some nicer. What we have more? We can have some smart gloves. Smart gloves which integrated lots of sensors and visualization tools. And if we go down, we can have smart shoe. And this is not some science fiction. Nike already sells smart shoes, and basically we also have an accelerometer included in the smart shoe structure. Regarding controlling devices, we might use neuro computing devices. In this case, this is a MIO device. That device captures muscle activity, and according to the muscle groups which are active, we can get some information about the gestures. So this person doesn't have ring. Maybe he is not married, but if he was, maybe he had some smart ring. So basically the smart rings, we also include the accelerators, and we can recognize some simple gestures. For example, if I had such a ring, I could just swipe my slides and I didn't have to press on the keyboard. Smartwatches basically they became something similar to our smartphones. I think the processing power also will be soon similar, and they can be used as additional means to provide the feedback. And some other devices like lip motions to detect the hand and use it like in some science fiction movies. As you can see, we have various devices, but the functionality overlaps. So I think in the near future, the companies will offer the subsets of these devices to provide specific functions according to the application. But talking in general, what mankind is trying to do, so basically the Iron Man or the costume of the hero. So basically what we have all kind of stuff you talk in the sessions. We have EEG, EMG, ECG, breathing rate, baby blood pressure, inertial sensors, and we could use that info in order to provide the costume that cares about person. So we have a project which is called CareWare, meaning that we have software and hardware which cares about you. We have quite a number of our colleagues, of partners, and in Lithuania we have KTU, Lithuanian Sports University, and maybe bigger player Audimas, which is participating in this project. So this is an example on how human or person physical parameters were measured until now in Lithuanian Sports University. Now, of course, everyone wants to get rid of a lot of stuff. So everyone wants to invent some comfortable wearable, in this case T-shirt, which would allow to get us the information we need. So basically what we have the T-shirt, and we have the sensors integrated into the textiles. Regarding our product which we are creating, well, I don't know all the sensors, because different partners they suggest different sensors to be integrated. Some are suggesting to integrate video cameras, but in our Lithuanian case we want to get cardiac signal, because this signal provides most information regarding healthcare. So what we do have, we have sensors, we have wires or wireless interfaces, we have detachable devices, because we have to wash our shirt, and we have the integrator, the main unit which integrates all the signals coming in from the global network, and that integrator uses the mobile phone for initial data processing and for working as the gateway. Okay, so how could we use that T-shirt? It could be used by the professionals, for the professionals, sportsmen. The data which is acquired could be used for the traders. Traders could supervise how sportsmen doing exercises, supervise their physical status. It can be used for the active or casual people. Of course, people not always will have supervisor, but if they don't, So the social networks comes in to help. And of course, the third case are elderly people who need constant monitoring. So this is the case for doctors to have the information we need. Regarding IT infrastructure, it's quite easy. We have our t-shirt. Integrator gathers all the data, provides it for our mobile phone. Our smartphone process initially the data and maybe can find some anomalies. If it does so, smartphone provides info in some way, for example, using smartwatch for our sportsmen or elderly people, and then the information is sent to the web server. Later on, the information is stored in the information system and can be accessed by our actors, trainers or doctors, and we try to do it almost real time, almost because we need some time for buffering the data before sending it out. And for a long time analysis, we might use some cloud computations. So the main challenge is not IT, I think, in this case. The challenge is smart textiles, because we have quite rough requirements. Our t-shirt must be first washable. Secondly, our t-shirt must be smashable. And thirdly, it must be comfortable. So this is the main challenge. Of course, there exist other challenges like data analysis. Our mathematicians takes care about that. Innovating sensors to make it cheaper and other stuff. And one important thing here mentioned social communication. Social communication, well, to bolster the motivation. Because we need the motivation, because that smart t-shirt will be not so comfortable to wear. If people have some sickness, so they will wear it. But if not, then we need to get some motivation. And here we need to use some methods to do it, and one of the methods is gamification. Gamification is when we use game thinking, game mechanics in non-game context. And if you had some application, for example, running application, you could see that the gamification is also often used. So we have lots of stuff which are used in the games, like badges, ranks, achievements, rating, and other stuff which gives us motivation to return to some activity. And most of you, I think, know the gamification. For example, when you go to some supermarket, you buy some stuff, you get these sticky marks, you put the sticky marks, well, on some paper, and when you finish gathering sticky marks, you buy some set of dishes which you even didn't want to buy, but you do it because you won the game and because you have some discount, for example. So the idea is to use such techniques also for sporting. If we talk about the gamification in our project, there are lots of things we need to consider. For example, how to measure improvement. if we are talking about the cardio signal. How important are the specific characteristics of that signal? How to convert it into points? And will it be actually important for the people? Well, to try it before doing, we can use some modeling. So we have some experts like Robertas in gamification modeling. So we might use our colleagues' experience. But if you don't like modeling, so we have 3 things upon which relies the gamification. So it's competition, reputation, and fun. So, and now that we have to mention Depression Day. So in order to get rid of depression, it's proposed to do both. It's proposed to do some sport activities as well as to have some fun. So I want to tell you about another our project, rowing project, which also refers to our smart t-shirt because it could be one of our pilot or test cases. So we have rowing machines where you can do some rowing, not in real. And the sportsmen usually do it all the winter when we cannot do rowing outside. And usually we also use some smart t-shirts, usually with chest bands, which measure heart rate. So what we can do, we can see the peak heart rate, we can see time spent above some safe zone, which we should not go above. We can see some time spent inside zone, meaning that we were active enough, and time spent below zone, meaning that we should have done it better. One more thing is that rowing, it gives lots of load on our heart, and it's dangerous for people with heart diseases. So, how to give people more fun? Our idea was to provide virtual reality. Usually people think that virtual reality is some kind of a game. So it's partly a game, but the main difference is that for virtual reality we need to remove the obstacles or boundaries between us and the game and the monitor. We want to be within the game, and we don't want to see the boundaries. So in order to do that, the humanity tried to get the monitor closer and closer to our eyes, and these are various HMD devices. And the flagship of virtual reality devices is Oculus Rift device, which has also positional tracking. Here, for example, is Gear virtual reality device that we can use our smartphones for virtual reality. Okay, so what we did, we used the Oculus Rift device, which has infrared light emitters, which we could map and get position of the head, also the orientation. This is a camera, and well, we can put the sportsman into some virtual world. Okay, so how it looks like here. We can look to overboard, to the left, right. There is some shark swimming. There are not a lot of sharks. in Trakai track, but the sportsman told us that it would be more interesting to add something, so we add sharks. On the right you can see the competitors. On the left, our beautiful Trakai castle. And you can see here how the positional tracking works. Now we have also the ore animation and other stuff. So in this way, I think it is more interesting to do rowing than just looking at the wall. Also, it shows at which position you are, and when you finish, it shows also some additional information like time spent, power, and so on. Okay, so I'm telling you that this is fun, but is it really? So we made a lots of presentations. I don't know if it's sound. There is a sound. No. Čia garsą kur galima jungti? Dabar. Randa. We had one little guy who didn't want to do rowing, thinking it was too big for him. He finished rowing, still he wants to do it more. Yeah. Basically, we made the Trakai track one-on-one. We take Google Maps and do it meter to meter.
Mačiau kitą plaukį. Ir su juo lenktyniavai. Jo. Pirmą vietą užėmė.
So you see the competition is very good.
Beveik vandenį, ar ne? Jo jaučiau, kad ten yra vanduo. Gerai, kad nesitikrai. Nes kai iš valties išgrįžčiau, tai valtis plauka. Tas tieso laiko požiūris. Kiek tau metų? 6. Beveik 7.
Okay, so basically you got the idea. This is our roadmap regarding the device. And what's next? So we have, of course, bikes. And bikes, I think, are more evolved than rowing machines. But I think it will be hard to go into that direction because a lot of software for bikes is done. But still we could use this on our test case using the smart sheets. And another thing where we are going when we are doing some research are the running tracks. So for the running tracks, we can also have some software where we can run, for example, in Chicago or other city. But I wanted to show where we are going. So I don't know if you saw this. This device is just being finished and enters a production stage. And it will be around the first quarter of the next year, of the year 2016. I tried to find some non-shooting demo. For example, sportsman running, but I didn't found that, so sorry about that. So as you see, there is a stable frame without moving parts. It has some bud around, so it's good for the rehabilitation. And the idea is simple. Maybe you remember the old mouse, the mouse which had trackball inside. So it's the same idea used here. We have trackballs inside our shoes, and when we go, so according to the direction of the trackball, it provides the information where we are going.
The feeling of immersion, of moving around naturally in the virtual world is mind-blowing. That's why we developed the army.
So I think this is the direction where we programmers and our colleagues from multimedia could work on, so that we can attract people doing sports. And regarding our research, we were also doing some free walking systems, which could be also used in sports, and especially when we need to get some data from sportsmen. And we use free Kinects to gather all the data about the human body, meaning that at any moment we could see the skeleton of the human. So it was quite interesting project, and finally we got that we need to. Here the person uses Oculus Rift to see virtual world around, and he can just go wherever he wants to. But in all, this project is quite expensive, and for people, even for clubs, well, it's too expensive. But as such, as the concept of proof, this works. Yeah, it's hard to get back into real life. Okay, so I think my time is up, so I will finish here.
Do we have questions? Questions, please?
Do you consider using not Oculus Rift, but for example cheaper solutions like, I don't know, Google Cardboard or whatever like that? Because
yes.
Google Cardboard is a smartphone plus €5 for the glasses, right? So it should be far cheaper than Oculus, for example.
Yeah, we consider this, but it depends on which application. For example, on the throwing machine, we need positional and direction tracking. So
yeah, but for example, I do have solution like that. It's not Google Cardboard, it's It's actually a plastic glasses,
Yeah.
and
Yeah.
the applications for that, like I don't know, some roller coaster or whatever, they do track.
Based on gyroscope.
Yeah, they use the gyroscope, so they can they change the view with my position of my head, so I can turn around. I can do almost all you presented here. So.
Yeah, almost, but we don't have
Yeah.
the distance between the beginning of our boat and our position when we do rowing.
Okay.
So we would need to add some more device to get this. But yes, we consider, and for example, in this, we made the broadcasting, and you can use Google Cardboard to see, to be in the competition and to see around everywhere. So it's a good thing. I like.
So you told about smart T-shirts,
Yeah.
but I have smartphone and smartwatch, and I need to charge it. Sorry, I cannot imagine charging battery of my T-shirt. There's a problem.
Why? You saw, I mentioned that there is a pocket for detachable devices, so I think the battery and all the stuff will be in there, so you cannot rush it.
Okay. If I may, one more question. Is it possible somewhere to, I don't know, download your rowing application, or is it just, or to check for myself? Because, for example, at our university there is a rowing machine. There is an Oculus Rift, and I would just love to row around track ICIST.
I think we will need to exchange contacts,
Okay.
because it's still in the development, and we have companies which are interested in sports club, and I think when we finish it, it would be definitely possible to download, and now we just can share the application so you can try it.
Okay, perfect. Thank you.
Thank you, Thomas, for excellent presentation. And now I would like to invite Giorgio Terracina from University of Calabria. Yes, Giorgio, the floor is yours.
Good morning, everyone. Well, it will be quite difficult for me giving my talk after this very, very nice talk. So I will have less fireworks, but probably my work will be useful in the back end of your sensor networks, etc. So what I'm talking about today is about some new techniques for actually comparing things, comparing mostly heterogeneous stuff, and as the title tells, we extended sequence alignment techniques. So I just briefly need, really quickly, because I don't think all of you are experts in alignments, just a few concepts about these. So alignment techniques basically stem from bioinformatics, where they needed to compare DNAs or proteins, etc. And aligning two sequences basically means to find the best way to transform one sequence into the other. And this allows to measure actually the similarity or the dissimilarities of these two sequences. And based on this, many edit distances have been introduced in several years of work. So here, for example, two very basic edit distances are introduced. The first one is the Leverstein distance, where you actually allow as transformations in the strings, insertions, deletions, or substitutions of elements. And here you can see that if you want to see how much are far the intention and execution words, you can apply this distance, and you can find that applying some kinds of transformation, you have a distance equal to 5. And another more basic distance function is the Hamming distance, where you actually allow just substitutions, where in this case you may compare only equally length strings. So here you have the same distance, 5, but you see that the differences are quite in different kinds of changes. Okay, applications are really wide in this of these edit distances. First of all, computational biology, of course, but also in natural language processing, in ETL tools for data integration, and that's cool. But one very basic assumption of all of these approaches is that you are actually comparing things from the same domain. So the very basic assumption is that if I have the letter N in the first word, then it will probably it will match the letter N in the second word. And this is obvious, this is clear, and it is what we expect, actually. The problem we are facing here is when you have strings or streams of data that actually come from really different contexts. And as we will see, this may easily be the case for sensors networks, sensor data. So let's consider this really easy example where you have these two strings, one only with letters and one only with numbers. Actually, basic edit distances will certainly fail because you are not able to compare them, and because alphabets are disjoint, so you don't have any matching. Okay, so can we do something if we believe that these two sequences actually may be related in some way because maybe they come from sensors looking almost at the same things? The answer is yes. We extended this basic notion of edit distances in which we consider the fact that this assumption of symbol identity is too reductive in some cases, and we did something more, because when you want to compare such kind of heterogeneous strings, probably a one-to-one correspondence is really too reductive too, and so you may want to be able to say, okay, similar things in the first string are similar to other stuff in the second string. Okay, so we want to extend this stuff, and what we did is precisely this. So assume, for example, that in those two strings I said before, in some way, somehow, you said, okay, you find, okay, that probably the letter A in the first sequence and the number 1 in the second sequence probably may express similar stuff, and similarly for the other one. So if I have now these new assumptions, I can compare the two sequences, and I can apply classical edit distances, and I can find a new kind of distance, which in this case tells me that probably these two sequences are actually related. Okay, so now this is what we introduced. We formally introduced this new kind of edit distance, which we call multi-parameterized edit distance, where actually in computing the minimum distance, the finding the best matching schema becomes part of the problem. Okay. This is not obvious, this is not easy, and in this case, okay, don't read this, I will probably skip. This is just to tell you that there is a formal description behind all of this. Just look at the example, okay? I kept this just for some questions in case. So, the basic idea is this one. Okay, you have some strings. You have these strings defined on some alphabets. Well, you want to fix your context, and now you may say, okay, how many symbols of the first sequence I want to be matched at most with symbols of the second, and vice versa. So, in this case, if I say, okay, one symbol of the first alphabet may match at most one symbol of the second, whereas one symbol of the second alphabet may match at most two symbols of the first. Okay? Here I have the alphabets, and I can try to find a kind of matching between these two alphabets, and I can, okay, let's say in this case I find this kind of associations between the alphabets, and now with this assumption I can compute the classical distance, and I can enumerate the number of transformations that I can make. Observe that here, saying that 6 and 9 may match on X, it means that anytime I find either a 6 or a 9 and I can match it with an X, it's okay for me. So now, something more involved, the other two strings, I can find distances allowing 1 and 1 in this case, and I have a distance equal to 5 in this case. But if on the same pair of strings I allow 2 and 2, having this kind of subsets, I can say, okay, the distance now is below is 3, and how many matchings do I have to allow? Well, it really depends. It really depends on the application context. It really depends on what I would like to find. So the approach is really general. Very quickly, how can we do this? Well, finding the optimal matching scheme allowing me to get the minimum edit distance is quite tough. Actually, we demonstrated that this is an NP-complete problem, so we must resort to some heuristic. And what we can do is, okay, let's try to guess the matching schema, giving you the best distance, and let's try to get one matching schema and then go around in the neighborhood of the schemas and find if you can improve. So going around and around and around, you can get the best value. Okay, I'm skipping all the details, obviously. If you're interested, please ask. I can give you some materials, some papers. So, how do we use it? We have very nice applications. We have some collaborations around. And the first one probably is really linked to the previous talk because it regards analyzing sensor networks. We collaborated with some colleagues in my university, which work also in a spin-off company, Sensiscal, which also builds wearables with sensors. So it's very similar. In this case, we used ARIA sensors. And in this complex context, one of the main challenges to find anomaly detection. And we found that this kind of analysis may be useful to find correlations between apparently uncorrelated sensors. And in this case, identifying such kind of correlations may allow you to understand if one sensor is starting to work not in a good way. So what we did, for example, we focused on some kind of sensors, just keeping it simple to temperature and light. So we know that in some cases, but not always, temperature might be influenced by light and vice versa. So we considered a number of such kind of sensors, and we need to work on strings, so we carried out a discretization. Observe that in this image we have numerical values for both kind of sensors. Well, it may be not the case, because in some cases you may have agents or more complex sensors that sends you alerts or messages, so it is not obvious that you just work with numbers. Okay? So in this case we had these kind of lines which have been discretized to strings, and you can have clearly different alphabets because the signals are different, the measures are different, the significance of these numbers are different. And also other interesting stuff is that you may have possible drifts in the signals, either because actually the measurement changes or because the behavior of the sensor changes. And you have shifts in time. Here, for example, in the correlation between time and light, you may have that temperature and light, you may have that temperature changes with a slight delay with respect to light and vice versa. And okay, this is something we use to measure the correlation, and we applied our technique to measure the possible correlation between different kinds of sensors. This is the test, one of the tests we carried out. So we placed some of such sensors in the building, in different kinds of places. For example, one in a lab which had artificial illumination and artificial conditioning. Other ones in a room in front of the windows, in the same room but far from the window in the corridor, and trying to find some kind of stuff. Okay? So we took all the data from this, and what was interesting is that applying our approach, we were actually able, first of all, to find the actual correlation we expected. So the sensors on the window had the light and temperature really correlated. This was like a easy test, let's just say. But also we found that the sensors within the lab were strictly correlated. Well, why? Because light and cooling stuff were actually related, because you open up light in the lab only when people is inside, and when people is inside, you open up the conditioning. So the two things are strictly related. Okay, and whereas we did not find any correlation, for example, in the corridor where lights are always open and you open and close the doors, so temperatures vary really easily, etc., and so on and so forth. And so we considered, we made some kinds of tests, and we found out how to single out those kind of similarities, and then after this we may analyze the subsequent data in order to check if an anomaly is present. And in order to check for good and bad anomalies, we did this. On these very correlated sensors on the window, we considered one sensor free of any stuff, and another sensor with just an opaque sheet in front of it. So we changed a little bit the context, but it should have been a change not really impacting in the behavior. And so we actually found that the complete stuff was still working, continuing finding the correlation. So the perturbation was not a bad one. It was something that could be happening, for example, a not really sunny day or something like this, and so it continued to work. The second application I would like to show is quite on a different topic. It's on brain medical imaging. We have a collaboration with the University of Lyon, where they really have a lot of issues on biomedical imaging analysis, and by now they are really interested in brain medical imaging analysis, where they want to analyze white fiber matters. This case is a little bit different, because as we will see in a minute, this context is not really as heterogeneous as I said for the wireless sensor. One first issue was to take the 3D problem to some string problem, first of all. And second, we need to arrange and to compare three-dimensional stuff, which is not really obvious, with the higher complication that there are things like symmetry that must be considered. They are not an issue if a fiber is symmetric for the doctor or not. So we try to apply our approach. By now they do this just by hand. This is really time consuming, and the problem is to get these fiber matters bundles from real brains, and to find these bundles, to analyze them, to analyze if they are good or bad, and this may allow to identify some kind of illness and so on. So this is a real interest in this stuff. So we tried to make two things. The first one, automatically clustering fiber bundles. The second one, finding models. Okay, as I was saying here, we did something different because, okay, we started from fibers. These are images, okay? We have just images of fibers in the brain. So we needed a way to change these images to strings, and what we did here is to divide each fiber in voxels and using the position in the three-dimensional space to give them a component in red, green, and blue colors with respect to the positioning with the three axes. And using this three representation, we then used symbols to express the various combinations, and so we got strings. Once we got strings, everything was quite easier, clearly. But now we are working on sequences on the same alphabet. So it seems, okay, you previously said that your work is good for heterogeneous stuff. Well, here the most important thing we used was not the different kind of alphabet, also the fact that you can match different things in the alphabets, how many times you want, or at least. We have extended, in this case, the approach because we didn't want over-matching the various stuff. In this case, we had some knowledge on the context, not all, because as I said, you may have oblique lines, not all lines are the same have the same obliqueness, but you know, for example, that a completely horizontal line should not be matched to a completely vertical one, so you can add some kind of constraints. You cannot perfectly state what has to match with what, otherwise you have found your fiber, okay? And we use this kind of constraints in order to get better results. And okay, this is the test. Okay, we took some phantom data in the first example, in the first kind of test. Here the expert manually labeled the cluster. So here consider that in each one of these bundles there are several thousands of fibers. So you have really a lot of fibers and you want to cluster them. Look, the expert says that for him these two bundles actually must represent the same stuff because of some biological reason. Okay? And this is the second one and this is the third one. So we applied our distance-based metrics. Then based on the metrics we applied a clustering, a classical clustering approach. Actually we tried several clustering approach. And we also tried one of the tools they are actually using. Well, these tools are quite difficult to be used because they have really a lot of parameters. They must go manually inside many kind of stuff. And as you can see here from the results, I'm clearly, due to lack of time, showing just some of the results. Here we find that our approach, while the existing approach was not really good in saying that, okay, these two are the same bundles, here, based on the fact that we can match many things to many things, we are able to deal with symmetry. The second one, just the third one was a little bit missing. The figure probably, the colors are not seen very good. It's less precise, but it's still quite good precise. We have quite a good precision. And the last application, before I run out of time, is about extracting bundles of fibers from some model. Well, in this case, let's see first this. In this case, the expert, the doctor, knows what he's interested in, wants to analyze one specific kind of bundle, okay? And so he can either draw by himself the model, of the fibers he is interested in, or using our approach, we can extract for an atlas of pre-labeled bundles one model for each kind of them. Okay? And here again, what we are interested in is to transform these fibers into strings like we did before, and we applied our approach. How can we apply our approach here? Well, in very similar way. We have a model which is still represented as a string in the end. Then we compare this string model with all the fibers and take out only those fibers that are really similar. Okay, so we use a threshold to check which fibers are sufficiently similar to the other one, and we take, in this case, all the bundle. So we used in this case both synthetic and real. In this case we took a real data set from the brain of a real person, and just cutting some of the tests we carried out. Here is an example of two models that have been drawn by the doctor, and these are the results that have been extracted by the system, and we measured, clearly we measured formally the precision and all the stuff. They are quite good. So we see that this could be really a really useful tool for the doctors, because now in order to analyze the state of the fibers in the brain of some patient, they just need to draw a line on the system, and then they immediately get all the fibers in the patient brain in order to look if there is something wrong or if everything is good and okay. And okay, I don't have the other slide. The interesting thing is that since everything is based on a threshold, the doctor may actually adjust easily how many fibers to show. If he's not really happy with this representation, he may change the threshold and see more or less things on the screen. And so it's really fast and really usable stuff. Concluding, I'm on time. So we basically, okay, in this work, which as you have seen has a theoretical part and quite rich application part, we first introduced this new kind of metric, which was not presented first in literature, allowing really a wide variety of new ways of comparing stuff. Now we have the freedom to compare everything, almost everything. You usually don't have the guarantee to find some kind of similarity. Obviously, we found that the very most important thing is to compare obtained results with a bunch of random sequences you may generate. So you should always compare the results of this approach with some random expected value, okay? Because now there is not really always a real meaning to the stuff. We extended this metric in order to have a semi-blind notion of what's happening behind your kind of analysis, and we apply this on some new kinds of things. We are already thinking of a lot of new applications like ECG or other medical streams, also on wireless sensor streams. We have some of kind of ideas, and if any one of you work in similar contexts, please contact me. We can share and compare. And if I got your attention, please feel free to contact me. Yeah?
Could this method be used for EEG data?
Yeah, as I was saying, we are thinking on how to use this. We certainly have to analyze a little bit better the context, because you know, we must see how much classical tools, because EEG are EEG with EEG, okay? We must see how our approach may be different with EEG. Certainly the fact that you can input shifts or shifts both in time and in amplitude probably may give us some much more grade of freedom, but we still did not try.
Any more questions? Thank you, Giorgio.
I was out of time when I gave it to the so thank you. Thank you.
So now we will have a lunch break, and after lunch break, please all attend the afternoon session. We will have the best paper awards. So please all attend. So I hope it's working. And we are here for a brief ceremony to award best session papers and also best conference paper. And it is a lot of job for me, so I would like to invite session chairs to help me. So please, Marcin, Giedrius, also where is Christian? Where is Christian? Christian, we are missing you. Yes, and also Rolf. So we have a lot of nice gifts, nice presents, but I am a little constrained by wire, so I please Gedria to help me. So we have special session on intelligent systems and software engineering, and I would like to invite Karsten Wolf. Karsten Wolf, are you here? Karsten Wolf awarded the best paper award for this session, and the gifts will be awaiting for you at the registration desk. So please, please come to the registration desk. And next session. Special session on language technologies awarded to Jurgita Kapačiūtė-Dzikienė. She has left, I know. So we will deliver in person. So a regular session on information technology applications. And the prize goes to Marcin Baturovic. So, Marcin, can you deliver?
I will deliver. Thank you. Congratulations.
Yes, congratulations. Very good paper presentation. So, the session on smart e-learning technologies and systems, and the best paper award goes to Prima Gustienė from Karlstad University.
We have Prima's representative, Gintara, could you take and give our best wishes and thanks to Prima?
Please.
My pleasure to finally shake your hand. All the best, all the best.
So we have a special session on the e-health management systems, and the award goes to Frederick Baumer. Frederick? So he will have to come next year to our conference. And the best paper of the conference awarded to Rafał Broczek and Damian Slota. So thank you all for this ceremony. And now we proceed to our regular session of invited speakers of Industrial Tutorial Day. And Vytenis, I would like to invite Vytenis Punys to make your presentation.
Ladies and gentlemen, thank you very much for coming, and thank you, dear organizers, thank you for inviting me. Well, I have a quite difficult task to prove that you proved ready. As the health informatics is the thing that the idea that health informatics is an interdisciplinary topic, I think it's already proved by today's program. We have quite various. You had quite various presentations, and I just took some titles from it, and I would like to apologize other authors, other presenters that I did not mention. Well, it might take too much my slides here, and I think that from the general presentation about general health informatics approach by Professor Rolf Engelbrecht, then how to say, classical, I should say, health informatics standards, applications in practice, ISO 13606 and LOINC, and well, up to the smart shirts. So it's quite a wide area of IT applications in healthcare, or even I should say not healthcare in itself, but the topic should perhaps will be expanded in very near future, involving different how to say applications, mobile devices, and it will go much beyond healthcare. Well, that old style healthcare, well, what we are using. Unfortunately, I do represent that old style healthcare IT systems, as I am working as an IT manager in the hospital, and well, I see a lot of, how to say, there are still a lot of problems to do and to solve by IT people. So there are a lot of challenges for information systems in healthcare. Well, I think I do try to point out perhaps most important ones. Well, first of all, the IT should help medical people, medical organizations to make accurate accounting of medical services for patients and the submissions on claims for reimbursement for sickness funds in Lithuania, well, for insurance companies in general. Well, so how to say, that's the main thing that will help any healthcare organization to survive or to have a, how to say, cash flow. Well, so that's assistance for economy and management of healthcare. Well, there's another thing that, well, we have the healthcare systems should take care about quality of services and their management. So, and to find the most effective ways to provide medical services for patients and citizens. So here it comes, how to say, IT is like should be like a tool for medical services management through public health. What how to say, where I think is a lot of future interest, and it might how to say, make explosion of IT in, how to say, healthcare, or so it's well, that we have a lot of new devices being integrated into the information systems in healthcare. Well, up to the personal monitoring devices used in sports clubs and so on. So, well, we have, almost everybody of us are using smartphones that could be easily interconnected with the monitoring equipment. and well, that perhaps will make, how to say, even more impact that we had until now. Well, regarding, how to say, that's perhaps the future. Well, but what's the today's situation? Today's situation is that, well, all these information systems should be extremely reliable. Well, and that reliability should be built into their architecture. Well, because when you install a new system in a hospital anywhere, well, it's empty, it works fine. The problem is that after pretty much of time, so the system is almost filled up to the top, and we start, and well, the IT people can see, how to say, face, well, reliability problems. So that's about heavy loading system, and well, here definitely all of us should share best practices, how to do that, well, and actually what are, how to say, sometimes, well, any system have advantages and disadvantages. Well, at least those people who are involved in the healthcare IT would like very much to share, how to say that, some kind of the knowledge about, well, some kind of disadvantages of the systems they are using. And how to say, well, and all the medical systems, medical IT systems, they should accumulate and store data for well, perhaps if compared in general IT, we have, as far as I know, for example, we have, let's say, efforts to make archives of digital movies that were stored on videotapes in TV. Now we would like, and we have some of them transferred into digital format, well, even available free of charge on the internet. Well, so, how to say, but that's only now. What's about the medical data? So some of the data should be stored for at least 25 years. Some of the data should be stored the whole patient life plus some years more. Well, it's a big challenge, regardless the idea that let's say cost for gigabyte of hard disks is constantly dropping down. Well, that's a general trend. If it is taken into account that there are technology changes in the hard disk. Well, if we say that, well, if we take the hard disk, which is, well, there are some hard disks that are 25 years old, so that's an antique, and the price per gigabyte will be extremely high. So if we want to keep in the general pace that of the, how to say, price per gigabyte is going down, we should have, we should foresee the migration of data from one system to another. That migration should be so seamless that end users should not, how to say, even should not mention that, should not find that. Well, I'll say another big thing which we see, which could we see that, well, that's definitely, as I told, well, new devices, so patients and citizens' involvement. Well, so sometimes I would like to know that my, for example, old grandma, obviously, is monitored by some device. And I'm going to my work, but if something happens, I should know that something should come to her, or I should come to her and give some assistance. Well, so how to say that? Definitely, patients and citizens, well, at least family members, should accept technologies and be involved in that. Well, good information system can also help to market, to assist marketing of services. So, to promote that, for example, one institution is more advanced than others, that they have short waiting times and so on. Well, in general, end users need extremely ergonomic user interface. Well, we should take into account that the healthcare environment has very conservative users compared to all the others. Well, we have there's the whole range of ages of employed there, and their ergonomics is extremely important here. Well, so just if we have some kind of a system upgrade, so actually that's my recent experience. So first complaint of the users using old system, the result was achieved during 3 clicks, now we need 7. So that's again should be foreseen. Well, I've already mentioned about long-term deployment of systems, and that's extremely important. Actually, those people who are working in the hospital or anywhere for the system, so systems should have some self-monitoring tools to inform people that something is going wrong direction before everything fails. So these are, I should say, not only IT challenges for IT, but challenges for a lot of people who are involved in the design and deployment of information systems and IT tools, IT technologies in healthcare in general. Definitely the new equipment is dependent on the physics, biophysics, and physiology, and medical knowledge in general. So that's also very important. So from this point, I would like to share some kind of nice news that this September, together with I will say that, I'm also associate professor at the IT faculty of Kaunas University of Technology, and together with the colleagues from Lithuania University of Health Sciences, we started a joint study program of health informatics this September, and we are trying to combine core modules of informatics study program with public health related study modules of the Lithuanian University of Health Sciences, trying to cover, starting from 2 specializations, biomedical informatics and e-health technologies, and hoping to expand the scope in near future. So in general, the curriculum covers such core modules like object-oriented programming, fundamentals of digital logic, data structures, software engineering, databases, computer networks and internet technologies, data warehouses and business data analysis. And you see, taking, quite much of health and public health related study modules like ethics in healthcare, fundamentals of epidemiology, human anatomy, basic of healthcare, economics, social medicine and public health, health politics and planning, healthcare management and quality. So there are some specialized modules covering medical informatics, so biophysics and human physiology, fundamentals of biomedical engineering, smart mobile systems and applications, and 4 alternative modules. So biomedical informatics is very strongly related to biomedical engineering topic. Well, so that's how to say, that's a trend for new medical devices. And for e-health technologies, well, we have a stress on information systems, design, case technologies, requirements analysis and specifications, graphical user interface, mathematical statistics, data mining, and development and deployment of network-based services. So that's how to say more information systems related. Well, there are some very special study modules, so biomedical signals, analysis of biomedical signals and images, e-health and telemedicine, fundamentals of health informatics systems, so basic e-health standards. And actually, what I already see from the practical point of view, what we are lacking. So it's a legal framework of data security, and including medical data security in particular, and underlying technologies. Well, I think that it's not the only thing that is, how to say, missing. But maybe somebody could indicate of you what can be done even more. As I told, so that's very much based on the practical. So that's because hospital starts from queue management. Well, we see, how to say, very similar displays like in bank or in any office. Well, for registration, we need to evaluate waiting times there. Well, so you can see very interesting spike in the very early morning. So that's how it could be explained. Some people come before the office opens. So the system is already working, so they press the button and are waiting half an hour until somebody of staff comes and opens. Actually, we managed to filter that very similar thing in the evening. Because there are somebody that presses the button and waiting time is something not tens of minutes but hours until the next morning comes. Well, so just I don't know how many of you are involved in the healthcare IT here in the audience? Oh. So luckily not everybody. Well, so just the picture how IT infrastructure looks in the hospital. So we have e-health information systems for medical services, accounting and medical data collection and interchange. Then we have picture or medical image archive, which is perhaps the heaviest information system if counted about the data collected there. So it's in Lithuanian situation, so it goes up to something about 50 terabytes. Well, we have laboratory information system. It's I should say it's in Lithuanian situation. It's very nice. We have it. Well, it was quite a nightmare some years ago, because all the medical equipment biomedical analyzers were very different. Well, they had no data interface and so on. Well, I already shown the queue management system. We have some old databases for mental health. Well, that's very important. It happens that it's very important because if people are making application to have a gun or to have a special kind of a dog, so they should have proof that they have no mental disorder during 20 or 25 years. So that's also that's registration for long-term nursing. Well, general system for finance and accounting, staff management, accounting, document management, email and internet, intranet, and help desk. Well, so what is missing here? I already mentioned. Well, there's very high need for internal monitoring tools for everything here. From one point, another thing, well, how to say, it's a great burden for IT people in the healthcare institution to manage users. So there is extremely high need to have some kind of common user database, like a Microsoft Active Directory, lightweight LDAP or something like that. Because when we have in the hospital, let's say we have something about 1,600 employees. We have about 1,000 users for e-health information system already. So just, 10,000 user accounts. If those systems are not integrated, it's it's not a nightmare. It's much worse. Well, from the IT point of view, so it's also a plenty of knowledge necessary because, well, nowadays all the hardware is, usually it's virtualized clusters of servers. So in, that's the moderate size of the hospital, we have 2 hardware server clusters and 35 virtual servers running around there. Well, somebody will say, if somebody will tell you have, so let's say 10 information systems, but 35 virtual servers. Why so many? Well, usually, usually every information system, it's very, it's much more, works much more reliable if separated into the application and database parts. Well, so that's, and well, we have some, some systems for replication and disaster recovery as well. So that's quite, it's quite a situation. Well, the IT in healthcare needs to know networking pretty well because, moderate size of a hospital, we are running in 10 different geographical addresses. So we need, VPN connections among everything, to have common infrastructure, common information systems as a core. And well, just we need we need constant management and constant monitoring of services provided. Well, just like a case, it's arrivals count of arrivals at emergency department around the clock. Different columns and in different colors are present different days of week. So well, there is some kind of a general care, and that's very interesting. That, for example, on Friday, Saturday, and Sunday, so we have peaks in the evening, Well, so that helps a lot to plan the medical staff assignments and timetable. Well, for PACS and imaging, I've told already that's quite, how to say, all imaging modalities, they produce enormous amounts. The more modern device, the more data it produces. So it's, I would say that's up to 10 gigabytes per 5 minutes pushed through the network and should be processed and at least included into the database. Reference into the database, well, archived sometime. Such amounts of virtually sliced humans need 3D processing. Well, and analysis. Well, already mentioned laboratory information systems. Well, so for, again, moderate-sized hospital has 11 different biomedical analyzers. Well, or any vial is marked by a barcode, well, scanned and tracked through the whole process. So actually, well, that's again recent situation. What we would like to do that the barcode, the vials should be marked with the barcodes at the very beginning of the sample, when the sample is acquired, and then processed. So within the laboratory information system, how to say, almost no patient data should be used. Instead, or as exception, it's only the final laboratory physician confirmation about the diagnosis, when it's sometimes it should be adjusted to the personal data and illness history. Well, and say that's from the very old times. Well, so there's a lot of medical devices already created, devices and sensors. Well, and actually we expect much more of them. So that's a great challenge for both IT people and the designers of sensors to use and to deploy standard data exchange that the new devices will be easily integrated into the information systems that are running already. Well, I was talking a lot about technologies, but definitely the focus of efforts should go to the users, I mean healthcare staff that are working, and patients and citizens. Well, we are, how to say, expecting that from one point, we are expecting that new generation, which is, how to say, using and very familiar with all smart devices, will bring a lot of fresh air into healthcare IT. On the other hand, there is a lot of, say, experience that, well, that medical services are used not only by the young generation and, well, older generation people, how to say, they are getting more and more conservative. So even if somebody starts with the Z generation, well, so when it's necessary, when it's time to get some medical services, it might be even less than X. Well, so again, focus of efforts should go to the users, patients, so to humans. And well, technology is should be a little bit behind, because without users, without human efforts, any technology will be useless. Well, so that's how to say my colleague's point of view. Well, I'm not sure if I'm completely wrong, so I would like to have some questions and to have some discussion on this topic. Well, so thank you, and your questions.
What's really interesting presentation. Have you considered outsourcing some support works and some, I don't know, information system designs to private companies?
Well, actually, I should say that almost all the systems, we don't use, we don't develop all the 10 information system on our own. So each one has an offer which is, let's say, a private company. Well, until now, usually we have a support contract from the developer, only regarding PACS systems. Well, so now, the developer passed the support rights to another company. So it's only one case when we can say that, well, now the support model is working on a more general basis. The problem, for example, we investigated the situation if we can, for example, purchase support from let's say, for general purpose PC support. And so unfortunately it happens that, for example, a company, yes, it can provide, for example, general Windows, Microsoft Office support for users, but when it comes to the, for example, to the digital signing of the sickness leaves connected to the sickness fund or through the social security fund, so they don't have enough experience in that. So and our users needs that. So that's a situation that we need to provide our own support. So maybe in some future we will have that some companies will evolve and spin off that could provide such kind of support for medical IT market.
Any more questions?
Yeah, I don't know the structure of your country in the direction, but in Germany, the doctors have educational measures by themselves from the Doctors Association, and they are linked to professionals like us, and so we are going for lectures to the doctors' organizations. Is that possible in your country as well? Because I think doctors, nurses are important for data quality.
Definitely yes. Definitely yes. So regarding the education, Lithuanian medical people are they do have those, like you described the scheme, like that self-education through their professional societies. Mm-hmm. Well, but the final licensing is done through governmental body, and that requires, partly that professional organization, partially that education should go through the universities. So that's again, and final licensing is through the governmental body, except the dentists. Mm-hmm. Well, so they still have independence in licensing, but the governmental body declared that they would like to cover dentists as well.
Any questions? So thank you.
Dennis.
Also,
There's a certificate for you.
thank you very much.
And now I would like to invite Julius Burkauskas from the Lithuanian University of Health Sciences to deliver his presentation.
So today I'm going to talk about low-intensity cognitive behavioral therapy for depression, which is delivered by computer. And I have a few aims with my presentation. One of my aims is actually to introduce you with cognitive behavioral therapy and its main principles. How does this therapy see depression? And then I'll talk a little bit briefly about the burden of depression, and then I'll go straight forward on low-intensity cognitive behavioral therapy done by computer and how patients could benefit from that kind of treatment. So I use this picture just because it reminds me that actually human life kind of resembles a life of the tree. And from the very beginning of the seed, the tree can be broken by stress. And CBT is cognitive behavioral therapy, has a nice way of actually dealing with stress and alleviating negative emotions and making sure that people know how to make their emotions less of the burden to them. So, the whole essence of cognitive behavioral therapy was expressed a long time ago by William Shakespeare, and it says that there is nothing either good or bad, but thinking makes it so. So it's kind of nicely summarized what is cognitive behavioral therapy. And just to give you kind of a taste of the therapy itself, I would like you to introduce with an example. Just imagine a situation where 4 different guys are riding bumpy roads from Vilnius to Druskininkai, and they get into the accident, and for all 4 of the guys, and they are riding with 4 different cars, there is an accident, there is a broken tire for each of them, and after that accident they kind of feel quite differently. One of them feels anxious, the one of them feels angry about the situation, then one of them feels really sad about the situation, and the 4th feels happy. Could you tell me what might go into these persons' heads at the moment they are experiencing the accident? For example, the one who feels anxious about the situation, what he might think? What will happen next? Yes, anxiousness is always about thinking about the future. And if he is thinking, oh, how I'm going to pay with the car, and my insurance won't cover for it, and my angry wife will be waiting for me, and how I'm going to tell her that I've broken the car. So this kind of thinking leads to anxiousness. What about the one who feels angry?
Maybe he's trying to find someone who is at fault.
Yeah, so he could blame the government for the bumpy roads and how the government is not fixing the roads. Or he could blame himself for being not careful when driving and getting into the accident. So the anger thoughts could be related to the thinking about your own fault and the fault of the other. What about the happy person? What he could possibly think?
I'm alive.
I'm alive. Everything is okay. Just the car.
I was thinking I'm missing the dinner with my mother-in-law.
Sorry, could you tell it more louder?
I was thinking that the happy person was thinking I'm gonna miss the dinner with my mother-in-law.
Great thinking, and he kind of finds a nice excuse not to go to a dinner with a mother-in-law. And of course, he could also think that it's time to change his old car into a new one, and the insurance is gonna pay for that. So it's a great thinking to have a nice, happy emotion. What about a sad person? What he could possibly think? You get into the car accident and you suddenly feel very, very sad. What do you think? Yes?
It always happens to me.
Yes, it's the essence of negative thinking of the depressed person. It's my fault, it always happens to me. Every time I'm into the car, I'm in the accident. You know? And this kind of thinking leads to negative emotions. And this example quite nicely illustrates the fact that it doesn't matter what world brings to us. The main thing what matters is what we think about the situation and how we interpret the situation in our heads. And this kind of leaves us with kind of different emotions just because of our changed thinking. So the scheme of cognitive behavioral therapy goes like that. First, there is a life event which triggers the negative thinking of the person. And it could be a car accident, it could be broken relationship, or some kind of bad thing that happens during the day. And if the thought is triggered that I never do anything right, I'm useless, I'm a pathetic person, I'm no good, then your thinking goes in the prefrontal cortex of your head. So this is this part of the head, and then this kind of thinking activates the back part of the head, amygdala, which kind of gives you the feeling, the sadness because of these thoughts. And just because you feel sad, the amygdala also activates the whole body parts, and you feel this tension in your body. You feel tired because of this emotion. And if you feel tired and tense and maybe apathic about the whole situation, it is most likely it kind of affects your behavior too. And if you feel that way, and if your body feels that way, then you kind of decide, no, I don't want to go anywhere today. I just stay in bed and rest for a little while, and just do nothing. Just take a rest, and that's all for today. And if that happens, then this person gets the confirmation in his head by thinking, yeah, I'm truly a pathetic person. I can't even go out of the bed. And I can't do anything about that because I'm feeling that. And he's truly feeling this situation. So he gets into this cycle of negative thinking, activation of his body signals. And that's the basic model of cognitive behavioral therapy and how it understands depression. So, going from that, depression is a huge burden to the society. And this is the disease burden measured in disability-adjusted life years, and the depression accounts for 10% of the whole problems, health problems, people are having, and this is a huge problem worldwide. It has a chronicity and recurrence of 80%, and once depressed, you have an 80% chance of getting depressed again, and 40% of the patients get depressed within 1 year and 50% within 2 years. So it's a huge burden to the person. And there is also problems with medications because we do not yet have the best possible medication for treating depression. And even if the patient is taking medication, it doesn't mean that his environment changes. And if the patient's environment doesn't change, then the whole situation repeats, and people do not want to use the medication again, and then they do not adhere to the treatment regime. So it's just medication can't quite possibly be the best option for the person who is experiencing a depression. So what is already known that detection and management of depression actually improves outcomes, and improved management leads to reduction of chronicity, absence from work, problems with colleagues, and effects on family. But it's also summarized that depression is a chronic, lifelong illness. And for repeated episodes, it exceeds 80%, and an average of 4 lifetime episodes of major depression episode of 20 weeks duration each. Means that 4 times during your whole lifetime, for 20 weeks, a person feels sorry about himself, feels that he's apathetic, that he's no good, and this is a huge burden for that person and also for the whole environment surrounding that person. And when he feels like that, there is also increased chance of suicide risk, and once hospitalized with a recurrent episode, whereas 15% chance more to death by suicide. And it's also a highly comorbid disorder, and when you are depressed, it's very likely that you also have panic attacks or phobias or obsessive compulsive disorder. It is good that in that situation cognitive behavioral therapy comes to help, and it is already known that it's quite an effective treatment for depression. And what this treatment focuses most on is the activity scheduling. It's the second part. If you remember the cycle I was talking about earlier, the most easy thing to change in that cycle is your thinking and your behavior. So the therapist talks with the patient and kind of introduces him of various possibilities to do certain actions. And he introduces, for a person who barely gets out of the bed, the first step would be just talking about getting out of the bed and taking a shower. This might be quite a challenging thing for a depressed person, but if he does that, therapist advises for him to reevaluate his mood after that. And what he gets basically is when he gets up and go to the shower, his mood improves. And this is a sign that your action can help you to change your mood. So the whole part, the first part, especially in chronic depression cases, goes with the activity scheduling of that person. And this is a really nice study by Dimitrian et al., which kind of gave a nice support of the evidence that cognitive behavioral therapy works for depressed individuals. And it was a placebo-controlled randomized trial which compared behavioral activation, cognitive therapy, and antidepressants. And what was shown that after 24 meetings for 15 minutes with the patient, those who did behavioral activation and cognitive therapy improved more than those who did just antidepressants. And this gave rise to the whole cognitive behavioral therapy to be implemented in various health settings, and in some countries even insured by the insurance companies. But this was only one study, and now we have evidence from more studies showing that behavioral activation, behavioral therapy is better than brief psychotherapy or supportive psychotherapy. That's why in Great Britain the stepped care approach was introduced, and stepped care mainly focused about the first step for the patient who starts feeling depressed. The first step is that patient has to have availability of resources to actually treat himself. And these resources were just the computer and the internet. So the patient who feels depressed kind of Googles the symptoms he is having, and he could actually access the government's site where he can register and start his own treatment. And he do this treatment purely by self-help. And then if he finds some modules of the treatment quite challenging to him, then there is a possibility to call a therapist. But this is also would be considered a second step in the system. And maybe first call could not even only be with the therapist, but with an assistant who can provide you feedback about how it is going on for you with your exercises, whether you're doing them right, and how to do them better. And after that, if everything is going bad for the patient, there is a possibility to meet the therapist. That's called stepped care. So it definitely helps for those who are with no other resources, especially for persons who live in the rural areas of the country and who first prefer to deal with their problems on their own. And for those who do not want to seek support of health professional, they can first access the internet, access the site, and start to do something on their own. And for most of them who do that, it helps. So previous review of internet-based cognitive behavioral therapy showed quite promising results, but we wanted also to look more about the pure self-help, besides the internet programs where there is no therapist, whether they can help patients who are feeling depressed or not. And what we found that actually there is quite promising results, and we looked at the Medline and Cochrane, first trying to actually identify the possible studies where they use some kind of cognitive interventions on the internet. And we identified 487 cases, but only 8 articles actually use studies with pure self-help without the therapist involved. And as I said, the results were promising. Actually, studies show a positive effect of pure self-help on patients. And I would like to show a program which is called Mood Gym. It's an Australian program, and it has the basic modules, the basic principles of the ones I've talked about. For the first part of the introduction for the patient, when he accesses the new gym, there is an introduction about the relationship between emotions and thinking. And it kind of gets the patient to wonder whether his thinking might actually be the reason he's feeling that way. Then on and on he goes with the behavioral activation, and then he can even download and access some relaxation materials, meditation techniques to practice on his daily basis for his mood to improve. And Mood Gym was the best program which showed the best positive effect for patients treated with for depression. And this was a study where they used Mood Gym. This is Powell's study, and this is a measure not of the depression but of the well-being of the patient. As you see, this is the controls in red, and in blue there are patients who were treated for depression. And you can see that from the module 2, so it's basically from the second week of the treatment, the well-being of the patients for those who are waiting for treatment and for those who started the treatment starts to differ. And it differs till the end of 5th week, the 5th module, and they are feeling better and they are feeling that something good is going in their lives. But the whole problem of these sites, these pure self-help modules, is that there is a huge attrition in this, in these studies. And for example, in the study of Powell et al., more than 900 of patients started the program, but for the 5th module was completed only by more than 100 patients. So it actually helped for those patients, but only a small amount of them remained during the whole program. So we kind of would like to think what could help technologically for these patients to stay on the program, not involving the therapist. Because the therapy is really expensive, and it would be a lot of work for the therapist to consult these 900 patients, but what could technologically motivate these patients to stay on the treatment and get the good results of it? And the second best study was by Clark et al., and it actually showed quite nicely that during the 32-week period, the intervention group, Clark has done the study with the treatment as usual group and not the waiting list control group. So patients who were treated as usual were getting antidepressants, and the rest of the patients actually had this access to the program. So this kind of nicely illustrates that it has the same effect whether you use antidepressants or whether you actually engage in some kind of help given from the internet. So, the use of internet-based interventions could play a significant role in strengthening the approach and increasing access to treatment worldwide. Thank you so much.
Any questions? Basically, more a psychology-based question. Because maybe I'm wrong, but for my very limited basis knowledge on behavioral therapy against depression, I knew that a certain role is played by the psychologist, the psychiatrist, or anyway, a medical doctor, because one of the elements that is involved in this kind of therapy is the transfer or redirection of the emotional behavior. There is any study that indicates since what point the self-therapy can substitute an aided therapy? Because maybe at a certain point of the treatment of the disease, it is mandatory to have a treatment by an expert, because those mechanisms otherwise cannot be enabled alone.
I think I understand your question in a way that actually the transference and counter-transference for the between the patient and the therapist might actually help to improve the outcomes of the therapy. It could be the case, but this kind of thinking goes from the old tradition of the counseling, of the mostly from psychoanalysis. And in behavioral therapy or in cognitive behavioral therapy, we used to think that it's not much of the transference, but more about looking towards the same direction with the patient. So you do not get involved into talking much about your relationship or analyzing your relationship between the therapist and the patient as you do in psychoanalysis. You talk more about, okay, you have this goal to feel better. What could you do to feel better? What could you think possibly to feel better? And this kind of helps patients to reach their outcomes more quickly than with traditional psychoanalysis, where the patient has to find his own answers through these relationships with his patient. And some studies which use quite known psychotherapists who introduce you to the cognitive behavioral therapy, for example, the Judith Beck or Kristen Podesky, who are well-known leaders for CBT, they tend to get more people who stay during the treatment because they know they're kind of having this person who gives you an introductory lecture on CBT, which is well known, very famous, and you do not get in touch with that person, but you can get the grasp of that he kind of speaks to you through the video. So this might also help. I hope I answered your question.
Absolutely, yes, thank you.
Any more questions? No, thank you. It's a great presentation.
Thank you.
And now I would like to invite you all outside of FFL to participate in the Move Against Depression event, where we will make our own special contribution to fighting for depression. So please welcome.
Entrepreneurship Center. We do build bridges between science and business. We try to take what our researchers create and find business companies that would be interested in investing, making joint collaborations. We also help our students and researchers create startup companies. And I will give you a short presentation of what we do, how we do it, and what are the results. So, a couple of facts about the university, about Kaunas University of Technology. Okay, so we have 11,000 students. We are a mid-sized university, but we are the biggest technical university in Lithuania. So we have our niche amongst Lithuanian universities and the Baltic States universities. We do have quite a few international students, because one of our strategic goals is attracting foreign students to the university. Our university is around 90 plus years old, so we already have 100,000 alumni, people that graduated the university and are now graduates. 330 PhD students who are normally the R&D workforce in the university, around 1,000 academic staff. One number I'm pretty proud of is 70% of all the R&D that's been provided to business companies, the actual R&D to business companies, comes from our university, from Kaunas University of Technology. So if business needs anything, a prototype, a technology, they come to us most of the time. Okay. The research at KTU is being put into 5 areas. Okay, every area has a very fancy name, but it's made looking at the European Union Smart Specialization Strategy. Okay, again, the names are very fancy, but basically it's diagnostics. This one is this one is IT. This one is chemistry. Okay. Building material and civil engineering. We do have 2 valleys modeled looking at the Silicon Valley in the United States, and we have 2 of those. Basically, there are 5 science and R&D valleys in Lithuania: 2 in Vilnius, 2 in Kaunas, 1 in Klaipėda. Klaipėda's one deals mostly in maritime, water cleaning technologies. Our valley, called Santaka, the name means the river junction. We moved some of our top researchers into our newest building for the university. Another valley is the Nemunas Valley. It's the biggest river in Lithuania, named after the biggest river. And they only deal in food technologies. So basically bread, milk, beer. Beer is the most popular visiting spot in the university, even big groups come in. Okay. Again, as I mentioned, this is our Santaka Valley. It's composed of 2 parts. One building is dedicated to our top researchers, and you can see the centers and institutes that moved in. Also, some of our IT, actually most of our IT is moving towards the new building. And the black building is a business incubator. So quite a few young business companies that start in the university, in academia, end up being incubated next to the researchers. Okay. What else? Again, as I mentioned, food competence center. Little known fact that 5 different kinds of beer in the market being sold today was created here in our labs. But we did not allow to use the KTU name on the label just because of legal implications, but it's being created here. They even bring some materials from New Zealand, from everywhere. So again, very interesting lab. Talking about activities, basically National Innovation and Entrepreneurship Center unites 4 academic institutions under its umbrella. So it's basically Kaunas University of Technology, Lithuanian University of Health Sciences, Vytautas Magnus University, they deal mostly in social sciences, and Lithuanian Institute of Energy. So 4 institutions combining their we are combining our forces to do all the activities. Okay, and our center's main goal, again, to build bridges, to help researchers talk to business, business talk to the researchers, and in the end bring in more money and more benefits to the researchers. Again, numbers. We do have a website called aptis.ktu.edu, and it's an informational system that has all the services and all R&D equipment assembled into one place with a simple Google-like search bar. So basically, we went through the university and we asked every researcher, what can you do? What are you interested in? Are you interested in working with business? What services do you provide to business, to other researchers? Okay, so 1,300 services is registered there. He also said, well, we have a lot of equipment in university. We have 19 departments. So, and very, very expensive equipment. For example, one device in the chemistry department costs 3 million euros, just single device. And we said, we should open it up. We should do open access. So business companies, students, other researchers can come in and use that equipment. So we took in and we made photos of all that equipment. We took the descriptions, all the keywords, parameters, and we put that online. It's easily searchable. We also asked our researchers, what do you have created? What have you created? Do you have prototypes? Do you have technologies? Let us look at it. And we also made a catalog of all the technologies that are available in the university for licensing. Okay? And in the result, university is now bringing in around 3 million euros each year just from business academia collaborations, from industry collaborations. Again, our center main activities is knowledge transfer. It's basically helping researchers transfer their knowledge. Intellectual property management, that's normally a usual activity for the universities. We do have a young business incubator, and I will show us a couple of examples of our young companies. Okay? Promoting business mentality within the university. Also, various consultations for science and business, for example, finding funding sources, what European Union funding calls are being open, so they can apply for that funding, we consult the researchers. This is the system that I mentioned. For example, every piece of equipment is photoed, it has a description, and business company can put in their request. And we are quite happy with the results because we just launched the system, and with no advertisement, nothing, we already getting around 1,000 unique visitors to the website looking at all kinds of. It's basically because the Google indexed all the words and people are just finding it through Google. Okay, not that interesting. Again, the solutions I mentioned is basically we have every single prototype, invention, technology described with photos, so a couple of inventions. Some of our projects from that catalog, for example, this device was created with NASA because the astronauts, they do have a problem when they stay in space. After 2 weeks, their brain starts swelling and pushing the optical nerves, and they start losing sight when they are in cosmos. So it's quite a problem, and it's not solved. So our researchers is working on that and has a working prototype. Another one is the first Lithuanian nanosatellite. We launched it last year. Okay, it was the first time Lithuanians did that, and we are very happy with the results. Not to mention that on the last night before the launch, the TV crew that filmed the satellite managed to break it. Okay. It was Saturday night, and we suddenly discovered we need to weld it. The aluminum. If someone tried to weld the aluminum, they know the fun. You need special gases to do that. It's kind of tricky on Sunday morning to do that. Okay? So, quite a bit of fun creating that satellite. Okay, this device is very interesting. It's a multifunctional care bed. The story behind it is very interesting. It's basically for the sick people who stay lying for too long because they get sickness on their skin, they get wounds. And the thing is, this was created by a student in the university for his own sick brother. He has a brother that's very sick. He has cerebral paralysis, and he lays down for a prolonged time. So one brother created a bed for his other brother, and then seeing that it works, created a startup company, and it's now being incubated within the university. And he attracted money from various governmental support structures, and also is talking to the actual investors about translating this to the market. Some of our other devices, for example, one of the strongest centers in the university is Faculty of Informatics. We do have a real-time computing system center. So they create devices that control the Internet of Things. Okay. Some of our chemists' inventions. This one is also, we created a device to smell the freshness of food, raw meat in the market. And it's quite tricky because from the decaying meat you get 300 different gases coming out. 300. And you can't identify one single gas. So again, quite an interesting project that united different departments in the university. It took chemists to do the actual chemical testing. It took electronic guys to do the insides of this electronic device, and it took programmers to actually code the mobile app in your phone. So, stage gate, not that interesting. Okay, that's for 2 years. We created 36 startup companies. Okay, in 2.5 years, we already have 45 startup companies. 2/3 of them are students. 2/3 out of those 45, so it's about 30 companies came from students. Around 20 of them are IT app, website, portal builders, but 15 companies came from the researchers based on their long year research. Okay. Startups community, again, we work closely with Aalto University in Finland to look at their model. Not really that interesting. Some of our partners, and we have a project with every single one of them. For example, this is the national TV service in Lithuania. They provide a kids TV show on Sunday mornings. So our students created an app for that show, and it's one of the most popular apps in Lithuania in downloads. So, for example, Intermedics company, it's a United States company working in healthcare. Basically, they work with emergency rooms. So they invested 100,000 euros for the Faculty of Informatics at KTU to create a creativity lab. So we bought a bunch of biomedical devices for the students to experiment in, and just created a sandbox. Okay, and I'll just launch a short video so you can see some of our researchers and some of our IT that we have. Okay.
how the first Lithuanian space nanosatellite, LithSat-1, looks like. It was successfully launched into space from NASA Center in the United States of America in 2014 and successfully completed the planned mission. This satellite was developed in one of the largest and most modern centers in Lithuania. In other words, in the National Open Access R&D Center within Kaunas University of Technology. The university actively cooperates with business companies. Therefore, the findings of research undertaken at the university often become innovations and widely used products or services. Companies often seek standard services. We can provide more than 1,000 of them. For example, to analyze the material's qualities such as thickness, adhesion, compressive strength. Also, we can offer specialized services such as the development of individual technologies which require exceptional competencies of staff and special research equipment. In the state-of-the-art laboratories of our university's open R&D, global innovations are being created by globally recognized research groups. The laboratories we house are among the best in Europe. For example, more than 50 ultrasound researchers applied in various industries are carried out in Professor Kazimierz Bashauska's Ultrasound Research Institute. The scientists from the institute have developed various advanced ultrasound research methods and technologies. One of them is applied for testing the fuel tanks. In order to test the fuel tanks for leaks by conventional methods, they must be empty. Therefore, the process takes time and is costly. The scientists of Kaunas University of Technology developed the modern ultrasound testing method, which is effective and fast. We developed the equipment which can be applied without pumping out and cleaning the fuel tank. Ultrasound wave signals are identified and measurements are made from the outside. This method allows us to detect possible defects inside the fuel tank caused by corrosion. The scientists from the Institute have developed the methods and technologies that help to perform the ultrasound examinations of the condition of wind turbine blades and to identify their defects. Moreover, they help to identify the properties of liquid plastic used in manufacturing of plastic products, i.e. density, viscosity, while it is still in the extruder. At the Institute of Materials Science, 13 doctors of science and researchers, as well as engineers, undertake scientific research and provide analytical technological services. The Institute also houses the Clean Room, which is furnished in compliance with ISO 5. High technologies are being developed there by using modern electronic lithography, ultraviolet light, nano-imprint lithography, deep reactive ion etching, and electronic evaporation equipment. For example, the Institute can develop and produce the whole cycle of optical security elements, from conception to its printing. The cycle includes all technological steps from the customized design to the final product, which can be used for protection of documents, for authenticity of various checks, etc. Among our customers are state institutions and business companies. It is important to note that originally, holographic security measures were made by us here in Lithuania. The scientists of Kaunas University of Technology also work with various carbon forms, develop various sensors which can monitor the mechanical loads in real time, register the changes of refractive index of various media, as well as micro and nano devices, micro electromechanical systems, micro optical elements, and the microstructures as scaffolds for stem cells. In the center of real-time computer systems, the modern smart systems collecting and processing information are being displayed. Those products have their direct application in real life, for example, in smart home systems. We face the problem of how to connect the different things in the environment in order for them to communicate with each other. For example, a refrigerator with a TV with a heating system, or a mobile phone. Our world is surrounded by various things, and they communicate through the Internet of Things. The smart systems developed at the university can not only meet the needs of a user, but also offer to order various services upon the customer's request. The Center of Real-Time Computer Systems develops and markets approximately 3 new products or technologies a year. This invention is patented in Europe, the United States of America and the EU. The radical innovation, in other words, the first non-invasive intracranial pressure meter in the world, developed by the researchers of the Institute, has already been used for intracranial pressure monitoring of NASA astronauts. More than 30% of astronauts' intracranial pressure increases and optic nerve swells in the space, causing blindness. The device, developed by Lithuanians, helps to research this still uncontrollable syndrome to select the candidates who are the most suitable for missions. Scientists have tried to measure the intracranial pressure without using invasive methods for more than 100 years. However, all attempts had failed. No one had thought of the principle of balance. We found the pressure sensor with one segment in the brain and another one in the orbit behind the eyeball. It is the ophthalmic artery, arteria ophthalmica. Thus, we developed the technology which allows using this artery as the balance by adding pressure to the closed eyelids, to the eyeball and the surrounding tissues. Unique ultrasound research, smart systems, non-invasive intracranial pressure meter, various micro and nano devices. It is only a small part of the inventions and products developed by researchers from National Open Access R&D Center within Kaunas University of Technology. Please contact the Management Department of Open Access Center for more information.
Everybody is stunned. So there's no questions.
Thank you.
And now I would like to invite Danius Knipska.
Hey everyone.
So the presentation, a roadmap, sophisticated technologies influence to business development, please.
Or something like that. Okay, seems to be working. So hello again, everyone. First of all, it's a pleasure to be here and an honor to be invited by a university into such an event. This naturally shows a great acknowledgement for a small-ish company as Adform here in Lithuania. The topic of this maybe story, it's not even a presentation I guess, is a roadmap, how sophisticated technologies influence business development. From the very beginning I have to be very, very honest with you. I'm neither a business development, aka sales guy, nor a very technical person. As you see below, I'm the research and development manager, so basically I'm talking to both sides while trying to kind of align one's expectations and the other one's capabilities. So today I'm gonna try and tell a few stories, naturally starting from me, Adform, the company I work for, something about investments, something about agility, Lambda architecture, open source, data science, and people of the world in general. I think Kaunas Technological University will be mentioned as well somewhere. So, first of all, yeah, disclaimer. Not everything I say is true. As I mentioned, I'm neither a sales guy nor a very technological person, so I might be wrong. And there are two main reasons. AdTech as a business, and AdFirm is in the advertising technology business, is very dynamic in both terms, business and technology. So some of the news might be out of date, well, maybe tomorrow. And the other statement is that many silver bullets miss the target, because there's many targets, and usually the silver bullets are just miracles. So, who am I? I'm Dainius. I'm with AdFirm for quite some time now, since 2008. Been in many different roles. R&D manager is the most recent one. Before that, I was an analyst. I was a product owner, if that role is familiar. I also was a part of the early data science team, which we're going to cover a little bit today. So been in many different projects, even more different projects. I like chess, and I also look forward very much to the next speech about electric cars, because automotive tuning is also something that excites me. And then uncertainty drives me. So basically, this is why I've stuck with AdFirm for so long, given that in these days it's very much common that people jump jobs 2 or 3 years. And yeah, I'm married. This is my lovely wife, and I don't have kids, but I have 2 dogs. Trust me, it wasn't easy to make these guys sit like this with the hats on. But we made it. It's all about the sausage. So, what's AdFirm? AdFirm is a company founded in 2002 in Denmark by 3 guys in a basement. In Vilnius, it started working in 2006, where the guys, by pure luck, opened a research and development and operations office. The funny story behind it is that they just met a couple of students from Lithuania in a bar in Copenhagen, randomly overheard that they were talking technology, asked them who they are, and they explained that they are programming students, and they just asked, could you do some programming for us? This is how it all started in Vilnius. From business perspective, it's now a global company. In 2014, entered United States. This year, entered Asia. 600 plus people and offices in 16 countries at the moment. Will be more. And as it was a pretty good idea by the previous speaker, I think I will also try and play this little video so that you get a better sense, in short, what AdFirm is and why at all do we work. Whoa. Why is it so weird noise? Do I need to turn this into here? Maybe let's try it one more time. Nope, we can do it this way.
This is a neat little story about display advertising and why it is such a drag. Say hello to Mark. He works as a planner in a media agency. Mark uses a zillion different tools, struggling with Excel sheets, trying to compare data,
Logging into several ad exchanges, calling different media to reserve advertising slots, calling clients, email media plans, checking out Excel sheets, calling some more, comparing, logging in, checking out Excel sheets, calling some more.
Well, you get the picture. Being a planner is a drag. And what about the customers? They see tons and tons of irrelevant ads. Just like Doris, she logs into her favorite dating site to see if she's been contacted by that knight in shining armor. And all she sees is ads for boys' night out theme trips to Vegas. Not the best match. This sends us over to Mr. Mario Marketing from Boys Night Out Inc. He dumps all his money into a big dark hole and prays to Vishnu, Harry Potter, Darth Vader, Paris Hilton and all other divine forces just to get a tiny chance of showing his display ads to an interested customer instead of Doris. In the midst of all this frustration, I bet you that our three friends asked themselves, well, maybe not Doris, but definitely the other two, wouldn't it be great to have a platform that closed the loop between media planning, buying, optimization, and reporting in one sweet interface for all online display advertising? But hey, that's what Adform is all about. We have that powerful platform with full support for real-time bidding, dynamic creative optimization, rich media, and attribution modeling, leaving Planner Mark with lots of spare time. Or if he's in it for the fame and money, with lots of time to tweak the campaign to perfection, making it the best performing campaign in the entire history of the internet, receiving a mountain of prizes and being celebrated without end. Of course, seriously boosting Mario's brand and skyrocketing his sales. And Doris, she is also happy. She clicked on a personalized ad and bought a romantic weekend in Venice with her knight in shining armor. Trust me, you'll never miss the days before Adform, making display advertising simple, relevant, rewarding.
So, I hope you got the picture of what Adform is, or what it isn't. And specifically, given that this is about the roadmap and how technology changes everything, I want to talk about one specific product that was enabled by very concrete technology. And that technology was Cassandra. Who knows what that is? Nobody knows. Okay, basically Cassandra is a very fast storage database. Key value storage, real-time operations, doesn't really run like reads, but definitely ensures that the writes are good. And it was the kind of cornerstone of one of our products, which we started developing in 2011. Now it's 40+% of the entire revenue. So this is the influence of technology on business development. Sometimes it's actually life-changing. And it's based on RTB concept, so naturally the question is, why would I tell someone in display advertising needs real-time systems? It's just like, what, you open up a page, you see the ads, you ignore them, and life goes on. But it's based on RTB concept, and it kind of relates to the video we just saw. The RTB concept is real-time bidding. It's exactly the same approach that high-frequency trading is doing on the stock market. It's just that the currency is added, and that's it. How it goes, you're opening up any random page. This page server sends out a request saying that, okay, some user, which we know nothing about or maybe know something about, is opening up a page. Do you have something to show to you? Instead of randomly showing something. And then multiple companies like Adform and Google and Yahoo and Microsoft, AOL or whatever, they score through their databases, and this is why it has to be very fast, because the window for your response is up to 100 milliseconds. That's tough when you get hundreds of requests, even tougher when you get, and this is our current rate, 1 million requests per second, like that. So basically we're now listening to the entire Europe and half of America in real time when people are browsing the web and trying to provide some ads. So yeah, then the decision is made via an auction, and you respond with a price that you're willing to pay. So in some cases you might notice that if the latencies are a little bit high, the page contents load sooner than the ads around it. So this is the latency introduced by the RTB concept. And this leads to talking about investments. Investments into knowledge sharing. It's not all about business. It's about ensuring that the people who work for you are growing, and there's enough flow in the talent market when you decide to expand. So this is something that we're investing heavily. I actually couldn't find the logo, or maybe it doesn't exist, for Kaunas Technology University Startup Space. But I know that a lot of our guys went there and gave lectures to the young people willing to make a change about different technologies, about business development, and so on. There's just a few elements where we're investing so that it's not about hiding something these days. It's about sharing how you do stuff. And when you all of a sudden feel the lack of power, you always know that in the market, your deeds will be known to a certain extent. Another investment, as I just gave one example, the DSP example, is to diversify revenue streams. For quite some time, Adform as a company was living off of what is called static ad serving. So it was just a company where you came, uploaded your banners, defined the timeframes, defined the websites where you want to show them, and that's it. Very simple model, very efficient, works like a charm. Gave us good food for, I don't know, 7, 8 years, maybe. But then the technologies kicked in, which allow a little bit more interesting approach, and you have to diversify. And naturally, to increase awareness. And one of my goals, speaking here, is to increase awareness in this group. This is the logo of AdBlock, which is now more and more kind of used across the web. But the ultimate question from my side is it every single ad that people want to block? Or is it just the annoying ones? And then, okay, yeah, that's good, you're right, thank you. So you want to block every single ad. Okay, good. Have you seen examples on the web, because there are popping up like that, where you open up a page, I don't know, some info content or some, I don't know, entertainment content, and it blocks the screen saying either you disable your ad blocker or send an SMS which is going to cost you €5 to view the site. Because the ultimate question is, who's paying for the content? Haven't seen some, but you will definitely, because there are already sites popping up like this who actively enforce you to disable ad blockers if you want to see the content. But that's the reality. Somebody has to create it, somebody has to pay for it. If the user is not paying, oh, okay, good. It's all good. I'm not talking about broad masses, but somebody has to pay for everything. And in this case, companies like us enable the advertisers to not annoy people. It's not the goal. We actually ban stuff like you're the millionth visitor and then blah, 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 and click here to win an iPad and all of these boring things. But as in the video, sometimes it's relevant. And if it's relevant, I don't see really much harm that it does to you. So increasing awareness that advertising technology is not evil. Well, Google also said that they were not evil, but still. Okay, and moving to the next story. To make the investment sound and work, you must follow one simple principle of agility. Starting from the very top of organizational structure, where you say no to silos. I mean functional silos. These are SQL developers, these are .NET developers, these are UI developers. And in previous talks example, I don't know, maybe it makes sense to just have all of the chemists in one room. But chances are that if you allow a chemist, a physicist, and a mathematician in one room, something more interesting might happen. So this is what I'm talking about. No more functional silos. You cannot afford that because they usually become bottlenecks. This is, well, not a very pretty image, but this was made up by our head of development, who naturally is a very poor designer. But this is our current structure. This is how we organize ourselves, and this is how we see how we work. None of these bubbles has limitations, but also they don't exist if they don't bring any value. Very simple network organization. We have value creation at every single point, and that's it. How do I do the laser? This is where I work. And here. And a little bit here, and a little bit here. That's it. So you actually have to organize, not by some hierarchies. Even though my title is manager, I only have one person reporting directly to me, while the teams that I'm technically running consists of like 35 people or something like that. But it's not about who you report to and under whom you are. It's more about what type of value you create. And this is a belief. It's not a proven method or something, but you have to believe in value creation. You have to keep your eyes on moving targets. As I mentioned, the ad tech business is very volatile and very dynamic. So if you try and jump on a target, whoops, it's over there right now. And you just made a leap which required a lot of energy. So baby steps, small iterations allow you to change direction a lot quicker. And hopefully this says something to you. This is the agile development process. There are many names: Agile, Lean, Scrum, Kanban, and all sorts of Scrumban. But ultimately, you have to be iterative and you have to be agile. Otherwise, you're spending energy uselessly. Get feedback. This is a famous internet picture. But the ultimate learning in terms of agility is that if you still believe that you look like this, while others are saying that you look like this, or by any chance if you have the courage to look in the mirror and see yourself like this, it's better to acknowledge that you have failed and do it fast. Sometimes you have to drop whatever you have been working on for like 2 months, 3 months, 4 months, maybe even a year, into the garbage can and start fresh. I remember one of my former colleagues was very proud of having multiple Microsoft certificates, which were along the lines of like Microsoft SQL 2005 professional, Microsoft SQL 2008 professional, then Microsoft SQL 2012. And I'm like, dude, we don't even have SQL anymore, and your daily job is not SQL anymore. It's long dead. Like you're collecting these certificates, but why are you wasting your energy? And then he left, because he understood that he loved SQL more than uncertainty, I guess. All right. So, following the principles of agility, there is one major problem with anything that's called agile, and that's the same uncertainty. If you're working in very small iterations, you never know what's the end result gonna be, because if you're constantly basing your work on feedback, you honestly have no clue how the product looks like in like 6 months. And this is why there is an approach. Lambda architecture is something that's also drawn by one of our engineers for one of our infrastructure systems, which is called Very Helpful Map. But basically, if you see, the whole flow looks like a lambda. And there are two main animals here, a turtle and a hare. While the hare is running in real time, processing some logs from some events, the turtle is mopping things up from the behind, and they both provide the same sort of information. But this one is more reliable, but this one is a lot faster. And ultimately, if you ask both of them for the same piece of information, this is what you get. You get the Lambda architecture. And here's some technologies that we're now taking a look into. Some of them are already used, but they're here just to illustrate that for every mechanism that you might want to employ, there's at least a few to choose from, and they're emerging, like, I don't know, every half a year or something like that. So it's a little bit of a continuous learning situation where we end up with. And in business, the Lambda architecture, well, this picture is well known, right? Strategic planning, we have the cash cow, and we have the crazy kid, and then we have the lazy dog, and so on. But if you just exchange the cow for the turtle and the cat for the hare, you actually get the same approach that eventually made it into technology from good old strategic planning books. Okay, open source. We have the agility, we have the uncertainty. This is why we need to employ some unexpected or maybe not very traditional in terms of technology ways of doing business. And this somehow tends to drive us to open source. Because unexpected relationships, like we just saw, technology and strategic planning. Microsoft loves Linux. And this is from Microsoft webpage. For those who don't know, they're now claiming pure love to Linux systems, and they're open sourcing their .NET framework, so crazy things are happening. But ultimately, if you want to stay competitive in the market, it's better if your product is developed like this. And this is the contributions to Hadoop. Hope you know what is Hadoop. It's like commodity, hardware-based storage, MapReduce concept implementation. Basically cheap, slow, but efficient way of computing things. As you see, sometimes synergy works like a charm. And it's all competing companies. If you take a look, like, I know, Amazon, Microsoft, IBM, EMC Squared, DataStax. In life, in like business life, they're all competing companies. But at the same time, they're all contributing so that the core foundation of their businesses is in the best possible shape. This leads to data science, because we have already talked about storage, databases, and then how to iteratively try and work on them. And just recently, some new term popped up. Well, recently, I mean, like a couple of years ago, maybe it came to the thing yet. Data science. And in the beginning, everybody thought that it looked something like this. Well, in reality, it's just three things combined. So it's statistics, engineering, and computer science. Why I'm mentioning data scientists here? Because this shows that technology not only changes the business for the company or the business model or the business development model, it also changes how we live. Because, for example, my mom is, well, she's a physicist, theoretical physicist, and she is now looking at Coursera courses, Introduction to Data Science. Because she's like, okay, yeah, I know a little bit of statistics back from the day, and I have a computer at home, and I'm a pensioner, why not have some fun? This is something that my mom never figured out, like, I know, 5 years ago. She was writing angry emails at me, usually. So yeah, technology is changing what is expected to be the driving force of the business. And I guess it's a very good message to the universities as well. Guys, combine these three into one and call it data scientist and teach some students. It's got to be a very good hit directly to the market. So yeah, we have statistics, we have engineering, we have computer science. There is only one small question. All of these guys need some sort of hardware. And for example, universities have devices which cost 3 million euros and you can go and rent it. Well, what if I have like 20 data scientists and they don't have 3 million euros just for experiments? What do I do? And naturally, my experiments usually don't require very specific hardware. It's just the computing power. We go into cloud, and that's yet another thing that's changing business. Cloud services, Amazon, Windows, Azure, IBM Bluemix. Well, technically IBM bought Bluemix. OpenStack, that's to be hosted if you have your own server farm. But basically the idea of the cloud is that you pay as you go, and you never worry about what's behind. You can just come and say, okay, give me 1,000 machines. I'm ready to pay, like, I don't know, $40 for half an hour experiment, and that's it. You launch it, you do your job, you get the output, you kill it, you forget it. What this means? This means that these iterative baby steps can be a lot quicker. You don't make them longer, but they can be a lot quicker. Because naturally, buying 1,000 servers, I think, would last for about 6 months, just buying them. And we get to the people of the world. What's happening with them? And actually, you already touched this topic, but I want to touch it again. The most famous causes out there in the world, and I actually say this sentence in every job interview that I have with the candidates for AFRM, is yes, the work is difficult and it's very challenging. And no, you're not going to go to your friends and say, I'm fighting cancer or I'm fighting poverty or something like that. It's not broadly accepted as a noble cause to work in something as annoying as advertising technologies. But I do want to mention once again to conceptual things, access to information, and back in the day it was saving the books, right? And that was a noble cause. People used to carry books around hidden, and while others were trying to burn them and so on. So that was somehow a noble cause. Nowadays, all of the information, well, most of the information is on the internet, but access to it, as I said, has to be provided by someone. But all of a sudden, it's not a noble cause anymore. And the other term is net neutrality, which also most of the advertising technology companies are fighting for, because I do hope that you imagine what would eventually happen if someone like Google just bought the internet, which they basically can do. And they're in the same business. They're like 96% of Google's revenue comes from advertising. And we use Chrome, we have Gmail, we use Android phones. They're everywhere. So neutrality is something that the smaller ad tech companies or like software development companies, because I actually look at myself more of a software development person rather than an advertising person. I don't really care much about like graphical designs or like psychological messages. All I care is technology and how to make it more useful. So net neutrality is something that the smaller companies are very actively fighting for, to try and ban monopolies over the internet. Because, well, you not only control the ads, you can control a lot of stuff. Summing up, it is great. The influence of technology to business development is great, very welcome, and we're super happy. It's just that special conditions apply. Thank you. Questions? If not, then no. Thanks again.
I have one question.
Sure.
How said you advertisement company, yeah?
It's not advertisement company.
But you're making advertisements, yeah? So you are making advertisements in the internet, no?
No. We're making sure that they're in the right place at the right time for the right person.
Yeah.
But the like physical drawings or animations or something, we have a couple of designers, but they're usually fixing stuff that our clients cannot fix themselves.
But if I have a banner, yeah, for some products, can I go for you and you can produce this on the internet or?
Yes, you can. It's just gonna cost a shitload of money.
Sorry?
It's gonna cost a lot of money.
Okay. That's all.
I mean, it's business.
Yeah, okay.
So we're not usually
I am
working with
only a
like,
student, I have not a lot of money, but...
No, I mean, we're usually working with media agencies as our clients, not the end clients, unless they're like huge companies. I know, directly, for example, Deutsche Telekom is working with us. So they have like a full department which operate on Apple system.
And price plans is page per click and or something like that? Or?
Sorry. No, sorry. Pricing usually depends on the market. It can be fixed. It can be budget shared.
Okay, thank you.
Thank you very much. It was very interesting presentation. So, our last presenter, Kęstutis Valinčius, will deliver a presentation on electric vehicle technologies, current status and future trends. And let's see, we already have an electric vehicle in our home, yes?
Yes. It was a secret, damn. So hello everybody. As Robert has introduced me, I'm Kęstutis. My name is Kęstutis. My first slide is on purpose without names, so I want to ask you some questions for you not to fall asleep, to be something interactive. So you heard that this presentation will be about electric vehicles, yes? So what is the first association when you hear electric vehicle comes to your mind? Tesla, yes. So what, some more? Silent car, okay, perfect.
Photovoltaics.
Pardon?
Photovoltaics. Pardon? Photovoltaics.
Yes, yes. So, more about technology. Do you think it's tomorrow's technologies?
Actually, yesterday.
It's yesterday's. Okay, so good. But President Obama stated in 2009 stated that these cars are technology of tomorrow. Yeah, I think he's an expert, but he said this on purpose, okay? So, as you are technological guys, you know this stuff, and you know that it's really not tomorrow's technologies, but about 90% of population really thinks that it's quite innovative, some technology. So, in my report, I will try to state that it's actually not tomorrow's technology. I will try to prove it, that it's not tomorrow's. But at the end of presentation, I will try to prove it that it's tomorrow's technology, okay? Okay. I think this don't work, so, okay. So, I draw a logo for this presentation because when I talk to people about electric vehicles and I say, would you change your car to an electric vehicle? They say, oh, I don't know, I have to think. So that is why the word caution comes to my mind. So electric vehicles is, people feel a threat about them because they don't know information. They don't know enough information how to know all this technology. So, as Robert has introduced me, I'm Kęstutis Valinčius, and I'm working in a science group that consists of business persons also. And so, my colleague Andrius is a member of Electric Car Association of Lithuania, and Lawrence is also an expert in smart, green, and integrated technology transport. So we have quite more scientists and other persons. One is sitting here also. We are trying to analyze all this domain and trying to do something innovative. So to some overview about my presentation, I will try to pass through some history facts. It will be not in detail, but just a very funny facts. Then I will try to introduce a problem, what I am trying to say, what problem I'm trying to solve. Then just give you a short overview about technologies, about the electric vehicles, and the current status, future trends, and what is the value of all these electric vehicle technologies. So, okay, so about some history, I will start with my own history about the electric vehicles, okay? About 1 month ago, I understand one thing. When I was little, I constructed toy cars from Lego, yes? I think you all constructed them also. So when I constructed a perfect car, I was driving through the room with that car, holding in my hand, and then I realized that it was boring, so I disassembled my cassette player, put a motor inside this Lego toy car, and I made a remote control from the music cassette box. So as a month ago, I understood that I have created an electric vehicle. So it was quite funny. So this picture represents not my vehicle, but it represents that this technology is really not so tomorrow's technology, and it is not so complex as we first think. So to come up next about the other technologies, I have also electric vehicle here. It is really not complex. So this vehicle has the same components actually, but in a small scale. So all the electric vehicle technologies are simple actually. Just they were forgotten for some time. So about the history, you know that the first vehicle ever constructed was an electric vehicle. Really, it was before the combustion engines, and it was about half a century before. But somehow it disappeared from the history. Then I won't mention other facts about the development of the process, but as you probably most of you know, maybe not, but General Motors in 1996 developed an electric vehicle EV1. It was a real nice looking car. It had a 6 kilowatt onboard charger. It had about 100 kilowatts of power, and it could drive about 100 miles in a single charge. As if we see today's cars, what we can buy, for example, from Nissan, BMWs, it is the same specification car. So imagine, it was almost 20 years ago. So what happened? So this period is named "Who Killed the Electric Car?" There is a movie, a documentary movie created about what happened. So it is a very sad story. The scientists and researchers somehow died in this story, and all the vehicles that were developed the company took them back and disassembled it and destroyed all this technology. So that is why you were right saying that electric vehicles is a yesterday's technology. Yes, we need to catch up all this time, because it is a very sad story about this. Okay, so what if these 20 years would be a technological progress? I think I try to imagine what would happen if we have 20 years for developing all the technologies, but this movie truly represents that. Really, technological progress for these technologies are evolving, and we are trying to catch up. And in today's time, we only have this, and we are still catching up. So about the problem, you know that electric vehicles are ecological and so on and so on. Yes, really, driving is truly ecological. Yes, it's truly. But another thing that to manufacture this vehicle is only cost for the environment, and also to produce the electricity for charging this vehicle also costs environmentally. But the main thing, we have to calculate and to measure what is better to drive in combustion engine cars, what costs environmentally more. But I think it's not the numbers, the fact, but the distribution of pollution. For example, every engine, even my neighbor moved the grass and using a combustion engine, really. So he's polluting my air. So if we can stay, for example, it is equally. Electric vehicles and combustion engines equally pollute the air, but the distribution, about the distribution. So the main problem is that we are localizing all this pollution to the factories and to the energy production power stations. So it is easily to solve the problem when it is localized, then it is widely spread. So I think electric vehicles doesn't solve anything, but just helps to find a solution for the problems. About the technologies, as you probably know, as you are technology guys, but just a short overview, we have the development of the battery electric vehicles. So when the power is stored in the battery and we are driving completely on electricity. The hybrid electric vehicle, when we have two engines combined, and plug-in hybrid electric vehicle, when we can just plug in, it means to the normal outlet, to charge internal battery and to drive some distance with the battery and the petrol. But as in the world, the situation is so strictly about environmental, and then some cities are shutting down shutting the city centers from the combustion engines. So driving electric car causes no problem, and also the plug-in hybrid vehicle cars also is good when, for example, we are driving in cities where pollution is forbidden, for example. So, but outside the city we can use a normal combustion engine. So this is also quite a solution. And also, what does this technological improvement help for the other normal combustion engine vehicles? So all technologies developed in electric vehicles also used in the normal combustion engine vehicles. For example, regenerative braking and so on. So we are not only developing new technologies, trying to adopt them, but also we are helping for the all technologies to evolve also. So about the current status, as you already stated, you have guessed my mind. So it is yesterday's, not the current or yesterday's status. So these are top 10 electric vehicles on the market, but this was produced, as we can see, yesterday. So today's situation is a bit different, really. I made this slide yesterday, so it is old. So we can see that we have almost all, we can state that all car makers are also producing electric vehicles. These are pure electric vehicles. So as we can see in the market, we have quite a rush right now. We don't hear from the advertisements, oh, buy electric new vehicle, but we just try searching the web and wow, BMW, Fiat, also Mitsubishi, wow, they are producing also. So it's quite fun to see how this is boiling. And there's a joke, of course not official, for example, the Fiat 500 electric. So the company, one of the CEOs stated that, not officially also, that please don't buy this car, we are forced to make this model. So as we can see, there's something pushed from above to make them, and they stated, please wait, we will develop the vehicle we want, so then we will proudly say we have an electric vehicle. So the market, the technologies are quite new, the adoption is quite new. So to mention something about the current status it's probably impossible. And speaking of myself and my colleagues, so this is a photo of exhibition a month ago. Me and with all our crew, we're trying to develop something new. And we just in exhibition we have showed a smart charging station, so we can control all this electric vehicle charging process via smart platform. So for example, mobile phone or wearables, also from the watch. It's like an experiment what we can do. We're just developing like a model, trying to see what the future will look like. So I'm stating that it is a current status because everybody is doing something into this area, and we actually don't know. There's a lot of researchers, a lot of scientists working in their labs and not showing. So how to know the future if we don't know what is now, really, yes? So I don't know. So the future trends, I just illustrate this picture truly represents the future, and we can say no idea. So this is the picture. I have integrated all the charging electric into a cup of coffee. It is a real charging station of electric vehicle. So it is truly represents that we have no idea what is going next, really. And to talk about the future, it is very difficult. But the main facts that why electric vehicles are not comfortable for most of clients, so it is the range problem, really, everybody knows that, range, and the charging time, yes. So speaking about the future, it's truly the range will extend and the charging time will reduce. And in conjunction, we will see that these type of technologies will be common, really common in our lives. So what is the value, really? What is the value about all this yesterday or tomorrow's technology? Really, with our colleagues, we have done a SWOT analysis about all these electric vehicle technologies, and we come up to some conclusions about the strengths. So what we have in speaking in Lithuania and also in Europe. So about the strengths. So we have strong position in business and science and IT and other specialized areas. Really, we have all these resources. We have strong science positions nowadays. The competence in production of components in EV. And active business actors are already in the field of EVs. As you can see from the history, the business tried to shut down all this process, all this development, and we can see that now the businesses are quite active and quite supporting all this technology. So I will not get into this why, but it is nice to see that the world is changing a little bit. And another strength is also the high amount of cars and population habit of riding cars, really. Speaking about weaknesses, we stated some of them: prevailing secondary markets of all vehicles and high global prices of EV and their batteries. Really, everybody thinks that electric vehicles are quite expensive and the batteries are expensive, but this topic is, I can say, over-discussed. Actually, these technologies are, in practice, they are not so expensive. It's empty talks, really. From my experience, I can say. Speaking about opportunities of tomorrow's or technology, so reduction of environmental pollution and noise in transport sector. This is the main problem. The reduction of dependence of the petroleum products. So it is quite widely spoken about them. Opportunity of businesses and science to engage in development of new markets. So, and the fixing low contamination levels of normal combustion engine vehicles is also an opportunity for electric vehicle technologies. And speaking about the threats, conservative approach by political agendas, really, we have experienced this in Lithuania also. And large state investments are necessary for the development of electric vehicle infrastructure, and still evolving electric vehicle market and uncertainty about its future. As I have stated, we have no idea what will come up in the future, so this area is still evolving. And the last but not the least, the lack of public information may lead to rejection of the electric vehicle technologies. Really, when I speak in the public to for example, from people from the street, and we can see that there are lack of information, really. They think that electric vehicles are something fantastic, but they're really not. So these results from the SWOT analysis found that the breakthrough impact on the local electric vehicle market can be created. So it is also a very perspective area that we can see. So this was my short overview about electric. I don't want to disturb you with the complex calculations, as it's the last report today and in this conference. So thank you for your attention.
Any questions?
Actually,
different variants of like electronic vehicles. So they can be hybrid and they can be all sorts of them. And now I'm looking at Wikipedia article about Lexus LS600H, which has a 5-liter V8 petrol engine plus like the hybrid version, which then makes use of some electric power to force additional horsepower. So in total it's 439 horsepower.
Yes.
But let's be honest, majority of it comes from the 5-liter V8, which pollutes, which does exactly the same, but the H letter allows it to drive in London without the congestion charge. What's your take on such approaches of business?
So these approaches, I welcome these approaches. So it is development process, okay? But when you drive in a slow speed, so your V8 is shut down and you're driving completely on the electricity, and this is that is allowed.
Yeah, I understand, but like, then you just go up like what's the maximum speed that the petrol engine doesn't kick in? Like 30, something like 35?
It depends on the vehicle, really.
Yeah, but usually box standard is about 30, 35.
Actually, it depends, because I have some information about other vehicles that has a technology involved that when you drive into the city center, you are not able to turn the petrol engine. Really, it's impossible. So maybe I was speaking about this. We can maybe it is the fact that we cannot start the petrol engine, so that is why you will not kick your petrol engine.
And the next part of the question, so how long do you expect that these like special conditions, tax exempts or I don't know, VAT discounts or something will be applicable to electric cars?
So it depends on the market. So why we have all these promotions for the electric vehicles? So when the number rises, until I don't know the exact numbers, when it reaches the level that it was expected, then all these promotions will be out.
I think 3 or 5 years.
And speaking about the time, as I have spoken about the future, really it is hard to estimate, really, because the market is evolving, and I think it's the time will not last for 5 years. I think 3 years maximum.
So you think it's going to be that soon that electric vehicles will be pretty standard and no benefits compared to a petrol car that will be available through governmental subsidies or something?
Yes.
I'll take that.
Well, in fact, you were talking the whole time about personal transportation and concentrating the problem. But, I mean, lots of the traffic on the roads often is not personal traffic. It's more like trucks or transportation of goods.
Commercial vehicles.
So, do you know anything about the state of maybe hybrid trucks or anything?
Hybrid trucks, there are some hybrid commercial vehicles also. Here in Lithuania there is a factory that develops this technology and integrates into Iveco trucks, and they can drive about from 30 to 50 kilometers on electricity only. But speaking about the problem, if it is the question about the problem, so as I have said, the range and the charging time is the main factor. So that is why businesses can't use these technologies in their everyday use, because the distances are high and the charging time, they have no charging time. So speaking about the commercial vehicles, they will be not so soon for electricity.
I know that the Norwegian Post Office almost solely uses electrical cars, so I think that there is definitely the possibility to do that, right? Somehow.
Yes, it is possible, but technological development should take place in the first place.
Post office type of work is a little bit different from, for example, long-haul flights, where you just take some bananas from one country to another one.
Yes, really, that's right.
Thank you.
Any more questions? So thank you, Kęstutis. And now before our final discussion panel, we will have a short technical break of 5 minutes.
coming. Let's start our last show tonight. Okay. So I would like to start with a general statement. I mean, data was and is everywhere around us. And nowadays, wearable devices, mobile phones open up vast opportunities to collect even more data and store it forever. Okay, so I would like to ask Mr. Rolf, how much data do we really need and use in our lives? Is collecting of data becoming its own goal and purpose? Should we talk about effective data instead? Effective use of collected data and not just collecting it all. Could you please? I'll just, yeah. Okay.
Thank you. And when I started in our new institute, this is now long ago, but we had also epidemiologists. And they did studies, started with that. And they collected data. I was responsible for a database, put this data into the database. And out of this database, they had to work the next 10 years to make knowledge out of this data, statistics and whatever. And even after 10 years, they restarted, took the same cohort again, and next study. But they were still not ready with taking all the data, so they needed a lot of data. And my feeling is our medical colleagues need many data. So from this point of view, I say yes. On the other side, I mentioned this morning a project called DiapCard. This is a project where we developed a data set, wonderful data set, about 1,000 items, whatever you need in medicine. And then we gave this to our medical colleagues. And the result was it's wonderful, but this is too much. And they had the idea, they had one sheet, A4, with I think 20 of 25 items. And this, they said, we need for 3 years on this card. And that's enough. So I think we have to look for the purpose of that. And in most cases, I think small data are enough. On the other side, if you want to do research with that and want to use, derive knowledge out of it, then you need more data because you never know for what purpose you need that data.
Okay, thank you, Rolf. Vitalis, right?
Yes.
You are head of IT department, if I'm correct. As an IT guy, what challenges do you experience in storing, maintaining, and using big data for the health sector?
Well, first of all, how to say, I would restrict, how to say, ourselves to the data which we need, which we collect on purpose. Well, just to collect data, well, to when sometime we will need it. Well, so nobody knows if we really will need it. Well, in the case of medical data, first of all, well, the first challenge is to use standard formats of data. Well, sometimes, and we should be ready to, well, some very strange situation. Just for example, we have plenty of medical image data. Well, and this is usually that data is compressed. There are standard compression methods. Well, perhaps one of the most advanced are wavelet compression, JPEG 2000. Well, for IT people, it's how to say, common standard used in multimedia, in imaging. Well, a little bit earlier it was simple JPEG. Well, and here it's how to say, it's very nice measure the compression ratio and the, for example, sensors. Well, it happened once that the company suggested to use very, how to say, fancy 100 megapixel X-ray detector, while usually general the X-ray detectors is something about, well, let's say about 5 to 7 megapixels, and it is 100 megapixel. Well, but when we looked at the data archive, we found, how to say, that the image file is, how to say, very similar in size, both coming from general purpose 7 megapixels and 100 megapixels. So in that case, it was very good, how to say, information entropy measure and demonstration of information entropy that, well, that 100 megapixel detector, how to say, has only the same information like this 7 megapixel. So, well, it's slightly, how to say, it's not a question which data we should use, which sensor we should use. When we store everything, for example, medical images have DICOM image DICOM are based on DICOM image standard. It's a special medical imaging standard. Well, now it's de facto and very interoperable one, very popular. There's much more medical investigation made with the electrocardiography, ECG, which is not as well standardized, well as how to say, there is not commonly accepted standard for ECG. We, when investigated, for example, we found, well, DICOM can store ECG data, and if looked straightforward, it's the worst in the sense of effectiveness of storage. So it has an even slight overhead. But when we investigate, well, the general proportion, the proportions, what part of such data is stored in the very big archives, so it's very funny. Well, the imaging systems, the image archives, well, are ready to manage, well, tens of terabytes of data, and that's, how to say, ineffectively stored will be something about 5%. So in that sense, it's, how to say, we will have very good situation that we will not, don't put much attention how to manage all the data. Just use a standard, and everything will work more or less fine. Mm-hmm. So, how to say, well, that's, I think that's the major point, that, well, we should find good and commonly accepted data standards to store the big data.
Dennis, I would like to ask you, we did have a chance to visit Ireland, a medical R&D center, and one of the problems they mentioned about medical data is that they do have, as they said, R&D data silos. So it's a lot of data being stored from different researchers on the same topic, and there is no way to combine the data and compare the data. So you do have the data, but it's very, very sporadic in different data centers, and you cannot actually access that combined knowledge. Do you also notice the same problem in Lithuania or not?
Well, definitely yes. Definitely yes. That's, how to say, that's very important problem. Well, again, I would come to, how to say, well, perhaps, well, the question is the reason why I've already mentioned the DICOM standard is important. Mm-hmm. Because, how to say, the problem is that different scientists collect the data itself, and they forget that that research data needs some kind of metadata, describing the situation and conditions, how this data was measured and acquired. Well, so actually, and that's the reason I'm mentioning the DICOM, because the DICOM, for example, it's, well, if it speaks about X-ray, so it's not only pixel data, but it's also, well, high voltage, X-ray tube current, and so on and so on. So there is, for each physical method of data acquisition, the data acquisition conditions are more or less, well, at least they are fixed, they are recorded, well, and then it's, how to say, perhaps a question of science to find the dependencies between those, how to say, slightly different acquisition conditions.
Okay, thank you, Mr. Vitanis, for your great input. Mr. Giorgio, it appears that informatics and big data is becoming one of the driving forces of interdisciplinarity applications. How you identify the right data to collect, and how do you avoid, again, having separate data silos, for example, in health-related applications?
Well, there is really a lot of research on data integration going on through the various universities, and I think that one of the main objectives should be that of trying to apply what the research have found in the last years about data integration and information exchange. There is really a huge amount of research on this topic. So I think that one important thing should be that of fostering this kind of information exchange between all of these sites that collect data. And about the problem of locating the right data, well, I think that it really depends on the applications, because there are some kinds of applications where you want to apply, for example, data mining techniques, which are really classical, where you actually want to start from a huge amount of data. In that case, the most data you have, then the better results you get. And so in those cases, you need a lot of data. In some other cases, you need to try to abstract your information, to select your information, but again, it is really a matter of the semantics of this data and what you need to do with this. So I don't think there is one single answer to this question, actually.
And yet another question that's quite important. How do you attract more young people to this field of IT, biomedical IT?
Well, I think that motivation to people and young people, first motivation is very easy to get about biomedical data, because when the people see that their job is really helping people, and it's quite easy. I have a student that graduated in our university that now is working in Lyon University as a postdoc, and he is working a lot with biomedical imaging, and some of the things I showed in my presentation was working with him. He is really excited, and actually probably I should not say, but he was the guy who provided his brain to actually take out the data. So motivation from one point of view is clearly given by the fact that young people can see the results of their work. And another important stuff more generally is that young researchers must know that they can work on their topic for not just a limited period of time. This, for example, in Italy is for the moment a very big problem, because university career is really difficult in Italy, and so often the students, okay, do their PhD, but they already know that who knows after the PhD what will I do, and so often they usually prefer to carry out more practical tasks, so they know that after the PhD probably they can get a job in a company, and this is not really good because we also need basic research.
Mm-hmm. And I'm very happy we do have a contract, the agreement with Group of Voss from Italia, and they tried to establish biomedical research center in Kaunas. So just a couple of weeks ago we asked about getting students for their activities. So thank you very much for your input. Coming back to the topic of attracting students, Mr. Danis, you come from the business side. Okay, I know of AdFarm Academy. Does it work? What are the success stories, and how do you build strong bridges between science, business, and students?
Thanks. Yeah, so as from Academy, it was briefly mentioned during my presentation, and I can just quickly go through the format. So it's a paid internship for students with little or no job experience. I mean, be any sort of developers, database, sysadmins, or anything that they want to try out. It doesn't necessarily have to happen in accordance with official internship period at the university. It can be summer, it can be any time of year. And they work in teams, so we carry out a normal hiring process, meaning that we have interviews with the guys, and the only difference between a normal hiring process is that we don't check their technical knowledge. But as opposing factor, we check their, well, so let's call it ability to grasp information and solve problems, because all the rest will be learned during the academic project. They usually last about 3 months, and the usual team is about 3 to 5 people. They get 2 mentors, one from the product and business side. So I was running 3 projects like that from product management side, and then they get a technical mentor who's reviewing their code, explaining the proper development processes and so on. No, I'm talking about software development projects. In total, I think we already had 30 plus of such projects. And I'm not sure about the overall statistics, but yes, they are working and they're very successful, because out of the 3 where I participated, we hired every second guy as a junior developer. So that's kind of a good high ratio, 50% out of all the people that got through. What's in it for them, even though they don't necessarily get hired? Well, they get some practical hands-on skills. They learn the processes and methods how, well, let's call it modern software development companies work. They get a chance to build up their network for future career purposes. Naturally, most of the students make use of the same internship for the university purposes, so that they don't have to do it again. And well, for us, as I mentioned, that's an investment, yes. Is it a worthy investment? Definitely. The bridge between students and AFRM is built just by the exchange of knowledge. And alongside, we pass through the university, which again can suggest better people to take a look at. And naturally, this helps our talent flow to be at a very sustainable pace, so that whenever we need to expand on a certain new project, we know where to turn to. So it's a great success. It's a lot of fun. And we're definitely going to continue that.
Is it popular among students?
Yes. Usually we get about 30, 40 applications into one position in a team.
Okay.
So the interviewing process is actually quite lengthy.
Okay. Because I know my experience of another company also has a similar academy in the university. So they said, let's create an academy. We will take 30 students and we'll just work with them. What happened, like 400 students applied, and they then had this positive challenge and positive problem, how to actually try to fit them all in, and that's where the university came in with all the lecture spaces and other things. So it's very good, and we really strongly promote having assistance from business, bringing in their know-how and using all the available resources we have at the university. Thank you so much, Dainus. And going to studies, electrical cars, Internet of Things, health. It's kind of a strange soup that you're brewing. Can it all really be connected and
Definitely, yes.
reap benefits?
Yes. So as we can see, electric vehicles is not only a transportation. It also, if we connect the vehicle to the internet, it's a smart Internet of Things, really. So our vehicle can get data, can measure data. For example, the driver's conditions, the driving conditions, and so on. So the electric vehicle, actually not only electric vehicle, but every vehicle, can serve as a sensor, can serve as a data mining machine, really. So to connect into all these technologies and involving technologies, for example, as an electric vehicle charging station, so we also can measure all the processes of the vehicles inside. So the vehicle is not only just a vehicle in today's understanding, so it can be as a data mining machine, as I have mentioned. So and speaking about the smart controlling and so on. So as we can see in today's market, what we are doing, we are creating autonomous transportation systems, really. So we have running autonomous vehicles recently, and we are testing. Not we, but in the world, the scientists are testing. So we are in the field of really new technologies. So this, as you have mentioned, soup, it's really tasty soup.
I've read a study, which point will be the next big breakthrough in mobile apps and mobile computing. And it said it's probably cars. Again, for the very same reasons. You have a bunch of sensors moving around, collecting data, working on it in real time, providing solutions, providing advice to the drivers.
Yes, so as you have mentioned, I can rename it an explosion. What is an explosion? It is right consistency, really. So when we had simple phones, and then smartphones appeared. So it was a huge demand, a huge market. As we can see, we have smartphones, yes, that's all. But we have cars right now. And we're just moving to the cars. And everybody, not everybody, but we have a large amount of vehicles moving. And to make them to serve for data mining, to serve them as a sensor, to help other people, to help globally. So we can use really these things to make them smart.
And I believe it's a bright future for IT programmers as well. There was a show called BBC Horizons about the scientific achievements, and they made a show about two universities competing in building a self-driving car and testing it near Las Vegas in the desert. So one team rebuilt the car, made all the mechanical driving and stuff like that, and another just wrote good software. So guess which one?
Software.
It's basically it was software in the end that made the main. Just because the mechanical things are prone to breaking, and the software really outperformed. So I believe the future still holds a lot of openings for the IT
on
people.
software, definitely.
Okay, but let's ask our audience. What do you think? IT, health, cars. What's your input?
I have one question, Dr. Tutis. There was an interesting point raised yesterday related with the challenges of new technology. Because what happens when the hacker takes over your autonomous electric car? How do you address this?
It's a great threat, really, and as scientists develop develops this technology, they are taking in mind all these threats, how to secure this, because it's a really great threat. It can cause injuries and so on. So actually, I don't know how they are dealing with this problem, but I'm sure that they are dealing mainly on this problem, and then later offering services. Yes.
Can I?
Yeah.
Sure, go on.
I also have a question to our guest from Germany. You were presenting one of the working things, which was health cards. And me and my colleague were discussing about why another card on the market or whatever. Why not use this, let's say, ID card or something like that to connect everything into one card?
Yeah,
What's your opinion?
No, first, of course, it's historical. We had a health insurance or insurance card, and we looked for a more intelligent on the card. And as Germany is based on law and whatever, we had a card with no sex on the card. So there was no picture and no sex. So you never knew if it is a male or female. And so the law was not changed because they said we will have a new card with picture on and so on. And yeah, this was the reason to have a card. And the second one was really to store at that time, you remember it was 2003. Internet was not like today, to store data on the card. Not many data, but some data. And then it has changed in the meantime, of course, that there are mostly not data on the card, but it's the access key to a network. And this makes sense because we have lots of people who are not, even not European citizens. They don't have an ID card, but they have to have a card for getting medical services. You see, we have more than 1 million Turks in Germany. And now we have refugees, as I said this morning. And so for this purpose, I think we need some other tool for identification. And why not a card? You have a banking card, you have a whatever card, and now, okay, I think it's the right tool. Of course, it could be differently. We could have one card for all purposes, using the internet. But we have to see also that people, mostly old people, are used to have a card like that. They're used to it, okay. Nobody asked for it. There was a long discussion.
In fact, there's another thing to consider in Germany. Historically, the same, Germany is still one of the countries with people are most aware of privacy issues.
Mm-hmm.
So it could be, that's another thing. So I think many Germans simply wouldn't accept or do not want to have their ID card coupled with their medical history or medical conditions.
Maybe.
I can just build up on that idea in one specific project due to the same privacy cautiousness in among our German clients. We actually had to swap cloud computing provider so that the parent company is not American. Because it was said by the clients in a belief type of statement that we don't want our data to be manipulated by someone who's owned by Americans.
Mm-hmm.
Okay. So, yes, the reasoning is very built into the mindset.
Yeah, we have history.
Yes.
Any more questions? Or input?
Yeah, I have a question to the electric car expert. There is a lot of research made for autonomous driving cars. And I'm asking always myself, why do I need an autonomous driving car? And if I buy a car, I want to drive it. Why do I need an autonomous car?
Yes, so this field, as I have mentioned in the conclusion, so population has a habit driving, yes, so we enjoy driving. But this field, autonomous driving, can serve like a public transportation systems for public transportation.
Yeah, for public
Yes. So this is one of the first fields that it will be applied, and later on, for example, as we see, in Lithuania, I can say everybody has a car. It's a small country, but let's look at the big cities. To have a car is really expensive, and they don't need a car. They don't use it. They use taxis. And they use public transport, and if they have an ability to use an autonomous car, I think they feel no difference at all. So in this case, they will achieve some profit from this, cheaper and so on.
I'd like to add to this also. If we talk about e-health and smart cars or whatever, autonomous cars, so you can imagine situations where a driver gets a heart attack or something like that.
That's so good.
And in such cases, autonomous car would
bring him to the destination.
you have all the sensors which diagnose your heart attack and so on, and you get
another case. For example, in Lithuania, we do have a problem with drink driving.
Yeah.
Driving when being drunk. So maybe a smart car can measure the air in the car, and if there are drunk people in it, just don't go.
Or disables the wheel.
Or disable the wheel.
Well,
Or drive by
disabling
itself.
the wheel, it's kind of maybe the gas pedal. The speed
Well, I
pedal.
meant everything, control.
Maybe like 20 miles per hour tops. So,
one more question. We talk about perfect network, perfect internet, perfect devices, but if someday there is no electricity, what we will do with all smart devices, smart sensors, and how we will take care with patients, which is or human? What we need to do in this case?
just before the answer, you know the Maslow pyramid of needs? So basically the food, safety. Have you seen they expanded the pyramid?
Yes.
On the bottom they put Wi-Fi and even lower battery life. Okay, so, anyone wants to answer? No electricity and no internet.
Well, I guess you can solve it by the same thing I mentioned earlier, the lambda architecture. You always have something that's way far ahead, but then someone needs to be your backup plan and mopping up things from the back. So even though the most modern companies still make use of, for example, tape storage in terms of data security. It's an archive, it's cheap, it's of course slow and so on, but as an archive it serves its purpose. And I don't imagine that someone is actually operating on that data, but just in case.
I'll translate the answer. Basically, take a bike that you can put to make electricity and take a couple of kids, and then you have electricity.
Well, on the other hand, just have you ever tried to forget your mobile at home and go to work? Well,
it's a great stress.
From one point, yes, it's a great stress, but on the other hand, you are very productive that day. Nobody disturbs you.
Yeah, but systems are not so productive if there is no electricity.
So
a little bit different.
Well, actually, if I can add just I think that still today, our generation will still be able to switch from electricity to no electricity. I think that in maybe 30 years, people will not know how to manage no electricity.
There is no need for so large period.
Maybe less.
If you have driving with GPS navigation and if his battery is dropped, most people they stop and wow, where
just in the middle of the lane.
So it's tomorrow's problem.
Coming to all these information system side, so usually the legislation says that you should have, similar trainings. What about disaster recovery without an electricity once a year? So, frankly, I've never was involved in such a training yet.
They should add no internet.
So no electricity, no internet.
disconnect one warning, disconnect the internet and check what
So simply for the disaster recovery, the information systems should have some kind of a backup energy sources and so on. And indeed, there's a requirement that we should, IT managers should, make the exercises what to do once a year about that.
Or maybe continuously. There is this famous story of Netflix and their chaos monkeys. Obviously, you know what Netflix is, right? Video on demand service. And they have a huge infrastructure and a lot of applications, a lot of systems, a lot of everything. And they have one system which is called Chaos Monkeys, which basically continuously, every single day, randomly kills stuff. It can kill a physical server, it can kill a network connection, it can kill a specific application, it can basically deny access to any resource that is available in the entire network's infrastructure. And every developer, day by day, has to work knowing that, okay, maybe today it works, and tomorrow the chaos monkey kick in. And you don't know what exactly is it gonna ruin. So whenever they build with that mindset that things will go wrong eventually. That's one way to enforce it.
It's like bacteria and body defense.
Something like that. Constant immunity building.
Self-defense. That's a good approach. We will try it at KTU. We'll just run through a server room, disconnecting stuff.
Maybe this today.
There may be another problem that with all these new smart technologies take the jobs of real people. When you introduce autonomous car, some of the, or many of the taxi drivers may lose their work. Also, when you introduce smart health systems with wireless nurses who care about at the patient's home, also may lose their work. So this cost of introducing a new technology will be too high. Don't you think so?
The society is getting older, so less and less people are going to work anyways. That may solve the problem on itself.
And that approach of thinking kind of resembles what used to be happening with music industry. When movies were accompanied by live music, and then they introduced the method to kind of literally record music, everybody was saying, no, wait, a lot of musicians will lose their jobs. No, you cannot do that. But somehow you still have orchestras. I attended music school back in the day.
I imagine
so,
this show, yeah, very, very good.
Yeah, but it's like natural evolution. And then
experience than recorded music.
Actually, I had exactly the same problem. The huge company in Lithuania that takes care of all of our electricity, by the way, and they have this problem. Trees grow. It's natural, but when the trees grow near power lines, they basically damage the power lines. And they said, can you create a drone plane to fly on the distant route and just just do infrared, whatever it takes to pinpoint where the risk areas are. And well, we basically mocked up a plan and said, yes, we can do that, it will cost that much. And you know what some of the answers were? What the hell are you doing? Do you not understand that around 100 people right now, the big jeeps, because they have to go to the countryside, all their fancy toys, they will lose everything. So you are killing a department, very, very lucky department in the organization with your innovation. Yet another one, they said, let's stop stealing of electricity and let's stop stealing of water. Okay, just put in some device that tracks it in real time. And there is another, no. Why? They need the size of the consumption. They do not need to make it lower, because they need users to spend as much as possible, even if it's stolen, because then they distribute it to the paying ones. So sometimes, even if you have an amazing innovation, no one really needs it.
They need it, they don't want it.
So it's not that easy, Alrighty, so I believe thank you to the panel discussion, thank you to the guests, and thank you for being here with us for 2 days. Interesting.
Yeah, this is.
I got two.
It's history, and you see, are very careful. We have no ID number, for instance. So there's.